Adrenal insufficiency is an endocrine disorder that occurs when the adrenal glands don't produce enough of one or more of the hormones, aldosterone, cortisol, and testosterone. Normally, the adrenal glands are stimulated to produce these hormones by adrenocorticotropic hormone, or ACTH, a hormone produced by the pituitary gland, a small gland at the base of the brain. Now, adrenal insufficiency can be primary or secondary. In primary adrenal insufficiency, there is plenty of ACTH to stimulate the adrenal glands, but there's an underlying problem with the adrenal glands themselves, like when the immune system attacks them. In secondary adrenal insufficiency, there isn't enough ACTH to stimulate the adrenal glands because of a problem with the pituitary gland, like a tumor. Okay, now the clinical manifestations of adrenal insufficiency can vary based on the cause. Nonspecific symptoms include fatigue, nausea, weight loss, and dizziness, as well as loss of libido or sexual drive, and amenorrhea or lack of menses. Some individuals may present an adrenal crisis, which is a medical emergency due to severe depletion of cortisol that leads to extremely low blood pressure, weakness, abdominal pain, and changes in mental status like disorientation. Diagnosis of adrenal insufficiency starts with a history and physical examination. Imaging tests, like a CT scan or MRI, can help visualize the adrenal glands or pituitary gland to identify structural abnormalities. Laboratory tests may also be done and include hormone levels and antibodies against the adrenal glands. Diagnosis can be confirmed with an ACTH stimulation test, which measures levels of cortisol before and after administration of a synthetic hormone. Treatment of primary adrenal insufficiency typically involves hormone replacement therapy. The type of hormone replacement depends on which hormones are deficient. Treatment can include a mineralocorticoid, like fludrocortisone, a glucocorticoid, like hydrocortisone, or an androgen, like dehydroepiandrosterone, or DHEA. Secondary adrenal insufficiency involves treating the underlying cause, which may include surgery to remove a pituitary tumor. Treatment of adrenal crisis involves intravenous steroids and supportive treatment. Alright, as a quick recap, adrenal insufficiency is an endocrine disorder that occurs when the adrenal glands don't produce enough hormones. Clinical manifestations can include fatigue, weight loss, and loss of libido, or signs and symptoms of shock. Diagnosis is based on history, physical examination, and imaging tests, and is confirmed using an ACTH stimulation test. Treatment involves addressing the underlying cause and hormone replacement therapy.
While doing your rounds, you see two individuals. First is Mike, a 50-year-old immigrant from Canada who comes in with a 5-month history of progressive fatigue, weight loss, and muscle pain. Personal history is unremarkable, but there's a family history of autoimmune disease. Examination reveals hypotension and diffuse skin hyperpigmentation, most pronounced around the oral mucosa, palmar creases, and knuckles. Then, you see Teresa, a 25-year-old who presents with acute vomiting, abdominal pain, and fever. She was accompanied by her mother, who mentions Teresa recently underwent transsphenoidal resection of a pituitary tumor. Examination reveals severe hypotension and altered mental status. Morning cortisol serum measurements showed decreased levels of serum cortisol in both individuals. Both people have adrenal insufficiency, although their symptoms are very different. Now, adrenal insufficiency is a condition where the adrenal glands don't produce enough adrenal hormones, particularly cortisol and sometimes aldosterone. There are actually 3 types of adrenal insufficiency. First, primary adrenal insufficiency is when there's a problem with the adrenal glands themselves. As a result, both cortisol and aldosterone production is deficient. It can be acute, usually due to a massive adrenal hemorrhage, or chronic, in which case it's called Addison disease. Now, a high-yield concept to remember is that the most common cause for Addison in high-income countries is autoimmune-mediated damage to the adrenal glands. In the rest of the world, the most common cause is infection, especially from tuberculosis, but it can also be due to HIV or disseminated fungal infections. Finally, bilateral adrenal metastases of cancer from somewhere else in the body can also cause chronic adrenal insufficiency. Then there's central adrenal insufficiency, which can be secondary or tertiary. In secondary adrenal insufficiency, the problem is not with the adrenal glands, but with the pituitary, which secretes insufficient ACTH. And since ACTH only regulates cortisol production, in this case, there's cortisol deficiency, but aldosterone levels are normal. This can happen with panhypopituitarism, when the entire pituitary gland is affected, and all the hormones secreted by it are deficient. Panhypopituitarism can be a result of any condition that affects the entire pituitary, like trauma, and pituitary tumors or large central nervous system tumors in its vicinity. And finally, there's tertiary adrenal insufficiency, where the problem originates with the hypothalamus and there's insufficient CRH secretion. So, once again, because there's no CRH to stimulate the pituitary to release ACTH, the adrenal glands won't produce cortisol. And because CRH doesn't influence its production, aldosterone levels are normal. Similar to secondary adrenal insufficiency, this can happen because of head trauma or intracranial tumors. However, tertiary adrenal insufficiency is usually caused by sudden withdrawal of chronic glucocorticoid therapy and resolution of Cushing's syndrome, which suppresses hypothalamic production of CRH through negative feedback. Now, when it comes to symptoms, adrenal insufficiency can be acute or chronic. The acute presentation is high yield and is called adrenal crisis. This typically occurs when the body is under stress, like when the person is ill or has just undergone surgery, and the adrenal glands can't meet the increased demand for cortisol. An adrenal crisis presents with hypotension or shock, vomiting, abdominal pain, fever, and mental status changes ranging from confusion to coma. The chronic presentation is more insidious. Some symptoms are nonspecific, like fatigue, anorexia, and weight loss, weakness, abdominal pain, and muscle and joint pain. Sometimes these can go unnoticed because the body can partially compensate for low levels of cortisol and aldosterone. Sometimes people with Addison disease can present with adrenal crisis when they're under stress. Alright, moving on. There are some symptoms specific to each type of insufficiency as well. In primary adrenal insufficiency, you need to know that there's hyperpigmentation, especially around the oral mucosa, palmar creases, and knuckles. Hyperpigmentation is caused by increased production of melanin due to a surge in melanocyte-stimulating hormone, or MSH levels. This is because MSH is a byproduct of increased ACTH production, since both have a common precursor called propionmelanocortin. There can also be a salt craving if aldosterone is deficient. Hyponatremia and hyponatremic volume contraction can also develop when aldosterone levels drop, since aldosterone normally enhances sodium reabsorption. The main result of volume contraction is hypotension. Another major function of aldosterone is to increase urinary potassium secretion, and without it, the kidneys won't be able to get rid of excess potassium, which causes hyperkalemia and subsequently metabolic acidosis. Additionally, on your test, there might also be either a personal or a family history of autoimmune disease, like diabetes or Hashimoto thyroiditis, which are commonly associated with autoimmune Addison disease. Now, in secondary and tertiary adrenal insufficiency, because there's no ACTH excess and aldosterone levels are normal, individuals won't present with hyperpigmentation or hyperkalemia. However, they might have symptoms pertaining to the underlying cause of insufficiency, such as headaches, visual abnormalities like bitemporal hemianopia, and features of hypopituitarism in those with pituitary tumors. Others might have a history of prolonged glucocorticoid treatment. Adrenal insufficiency diagnosis is also very high yield. Testing begins with a morning or random serum cortisol measurement, where a low cortisol level confirms adrenal insufficiency. Now, if there's adrenal insufficiency, serum ACTH levels should also be tested. If it's high, it suggests primary adrenal insufficiency, whereas if serum ACTH is low, it suggests a central cause. either secondary or tertiary adrenal insufficiency. Next, an ACTH stimulation test can help confirm the diagnosis when the morning cortisol level is inconclusive, and it can also help differentiate between primary and central disease. In this test, the individual is given cosentropin, which is a synthetic analog of ACTH, and serum cortisol levels are measured before and after the analog is given. Low cortisol levels before and after cosentropin administration confirm primary adrenal insufficiency because adrenal pathology prevents the release of cortisol. In contrast, if cortisol levels rise following cosentropin administration, that means the adrenals are responding properly to ACTH or its analog, confirming central adrenal deficiency, meaning the issue is either with the pituitary or the hypothalamus. Now, if this test is also inconclusive, a metyrapone stimulation test can be performed. Metyrapone is a drug that blocks the conversion of a precursor called 11-deoxycortisol to cortisol, and the test is based upon the principle that decreasing serum cortisol concentrations will result in an increase in ACTH if the pituitary and hypothalamus are normal. So, if after the test ACTH levels are high but 11-deoxycortisol levels are decreased, that confirms primary adrenal insufficiency. If both ACTH and 11-deoxycortisol are decreased, that is suggestive of secondary or tertiary adrenal insufficiency. Next, if we suspect primary insufficiency, then serum aldosterone and plasma renin activity should also be obtained. Renin normally stimulates aldosterone release, so with primary adrenal insufficiency, there will be low aldosterone and high plasma renin activity. On the other hand, if there's a central cause, then a CRH stimulation test can be done to differentiate between secondary and tertiary disease. That's where an individual is given a CRH injection and ACT is measured before and after. No rise in serum ACTH compared to the basal value points to a pituitary or secondary cause, and if serum ACTH increases, then the hypothalamus is to blame. So it's tertiary adrenal insufficiency. Treatment for adrenal insufficiency consists of lifelong hormone replacement therapy with glucocorticoids, like hydrocortisone. Mineralocorticoids like fludrocortisone should also be added in cases of primary adrenal insufficiency with decreased aldosterone. Individuals should also be advised to wear a bracelet that mentions they have adrenal insufficiency in case of adrenal crisis. For this dangerous condition, treatment should be initiated as soon as the diagnosis is confirmed. In an emergency setting where an individual has severe hypotension, intravenous fluids and IV hydrocortisone, a synthetic corticosteroid, should be administered immediately. Now that we've covered the basics of adrenal insufficiency, let's talk about some specific causes. So, starting with primary adrenal insufficiency, or Addison disease, if the cause is autoimmune in nature, it's called autoimmune adrenalitis. This can occur on its own, or it can be a part of two inherited polyglandular autoimmune syndromes that affect different endocrine glands. Polyglandular autoimmune syndrome type 1 is associated with Addison disease, hypoparathyroidism, and chronic mucocutaneous candidiasis, most commonly affecting the mouth, skin, and nails. These individuals often have primary hypogonadism, where the gonads are also damaged by autoantibodies. Polyglandular autoimmune syndrome type 2 is associated with Addison disease and autoimmune thyroiditis, in which case it's known as Schmidt syndrome. In addition, hypogonadism and type 1 diabetes mellitus may also be present. Autoimmune adrenalitis can be diagnosed by identifying elevated levels of serum anti-adrenal antibodies, particularly anti-21 hydroxylase. When it comes to Addison disease caused by an infection or malignancy, diagnosis is based on a workup which should include a chest x-ray and a tuberculin skin test to look for evidence of tuberculosis, and, if confirmed, anti-tuberculosis medications can be given to treat the infection. Screening for HIV infection can be done with PCR or with antibody antigen tests. If an HIV infection is the confirmed cause, antiretroviral therapy should be initiated. Finally, a CT scan can also identify adrenal metastases, which most frequently come from lung, breast, stomach, and colon cancer, or lymphoma. In these cases, treatment with hydrocortisone and fludrocortisone should also be initiated before surgery or chemo and radiotherapy. Another rare cause of primary adrenal insufficiency is adrenoleukodystrophy, which is an inherited disease that predominantly affects young males. The condition is an X-linked recessive disorder. The defect is actually a mutation in the ABCD1 gene, and it interferes with fatty acid beta oxidation. As a result, very long-chain fatty acids accumulate in various tissues, and they particularly affect the white matter of the brain, the adrenal cortex, and testes. So, besides adrenal insufficiency, they will also have neurological problems, like seizures, blindness, quadriparesis, and cognitive developmental delay. In severe cases, it can result in dementia, coma, and even death. Diagnosis begins with blood tests which show elevated plasma concentration of very long-chain fatty acids, or VLCFAs. In individuals with elevated VLCFAs, molecular genetic testing confirms the diagnosis, for which lifelong therapy with hydrocortisone is required. Another important cause of adrenal insufficiency is congenital adrenal hyperplasia, or CAH. This is a group of autosomal recessive diseases caused by mutations in the genes that encode the enzymes involved in cortisol and aldosterone biosynthesis. As a general note, if the deficient enzyme starts with 1, it causes hypertension, and if the deficient enzyme ends with 1, it causes virilization in females. When it comes to 21-hydroxylase deficiency, remember that 21-hydroxylase converts progesterone into 11-deoxycorticosterone, an aldosterone precursor, and 17-hydroxyprogesterone into 11-deoxycortisol, a cortisol precursor. Its impaired function leads to low levels of cortisol and aldosterone, and high levels of ACTH, resulting in adrenal gland hyperplasia. It also leads to excess production of androgen precursors, since their production is also regulated by ACTH. It's important to know that 21-hydroxylase deficiency can lead to 3 distinct syndromes depending on the residual activity of the enzyme. First is the classic salt wasting type, which is caused by severe 21-hydroxylase deficiency. In this case, females present with ambiguous genitalia at birth due to excess androgen precursors, and males present with failure to thrive during the first 1 to 2 weeks. They can also have symptoms like dehydration, vomiting, and hypotension, mostly due to aldosterone deficiency. Second is the classic non-salt wasting type, which is due to moderate 21-hydroxylase deficiency. This is when females develop ambiguous genitalia at birth and males develop signs of early virilization, like pubic hair, accelerated growth, and a large phallus at 2 to 4 years. And third, there's the non-classic delayed type, which is associated with mild enzyme deficiency. This is when school-age boys present with early onset of puberty or sexual prematurity, and in addition, females develop acne, hirsutism, and menstrual irregularity. Okay, so screening for 21-hydroxylase deficiency involves measuring serum levels of 17-hydroxyprogesterone, which are usually higher or very high in affected individuals due to them not being converted by 21-hydroxylase. In the salt-wasting type, another clue is that blood work might also show hyponatremia and hyperkalemia due to aldosterone deficiency. Other characteristic findings include decreased levels of mineralocorticoids and cortisol, increased levels of sex hormones, and decreased renin activity. And finally, something else to keep in mind is that treatment consists of hormonal replacement with gluco and mineralocorticoids to suppress pituitary secretion of ACTH, which will also normalize androgen levels. Okay, so there are 2 more types of CAH to remember. First is 11-beta hydroxylase deficiency, and this enzyme converts 11-deoxycorticosterone to corticosterone, and 11-deoxycortisol to cortisol. It presents similarly to 21-hydroxylase deficiency, with the important difference being that it causes the accumulation of 11-deoxycorticosterone, a mild mineralocorticoid. This can lead to hypertension and hypokalemia, even though renin and aldosterone levels are low. And then there's 17-alpha hydroxylase deficiency, which is very rare. The enzyme is active in both the adrenal gland and the gonads, where it converts pregnenolone to 17-hydroxypregnenolone, and progesterone to 17-hydroxyprogesterone. This means 17-alpha-hydroxylase deficiency leads to impaired synthesis of androgens, estrogens, and cortisol, but does not affect mineralocorticoid production. On the contrary, high ACTH levels cause excessive production of 11-deoxycorticosterone and corticosterone, which are mineralocorticoids that cause hypertension. The clinical picture here is dominated by the lack of androgens in utero. This means males will have external genitalia that appear female at birth, without having any internal female genitalia, whereas females will have the typical internal and external female genitalia. Then, at puberty, due to low levels of sex hormones, male individuals won't develop secondary sex characteristics like body hair, breast enlargement, and voice deepening. Additionally, menstrual bleeding won't be triggered in females. Individuals might also experience symptoms suggestive of mineralocorticoid overproduction. When it comes to blood work, you can typically find decreased levels of aldosterone, cortisol, potassium, and renin activity, and increased levels of 11-deoxycorticosterone and sex hormones. In 17-alpha-hydroxylase deficiency, however, there's increased levels of mineralocorticoids and decreased levels of cortisol, sex hormones, potassium, and androstenedione. As a quick summary of the three types of CAH, 21-hydroxylase deficiency and 11-beta-hydroxylase deficiency cause females to develop ambiguous genitalia at birth, while 17-alpha-hydroxylase deficiency causes males to have external genitalia that appear female at birth. 11-beta-hydroxylase and 17-alpha-hydroxylase deficiency both cause hypertension, but 21-hydroxylase deficiency does not. Okay, let's move on. The last cause of primary adrenal insufficiency we'll go over is Waterhouse-Friderichsen syndrome. This is an acute syndrome caused by bilateral adrenal hemorrhage, usually associated with severe bacterial infection. Although many microbes can cause this, the most likely scenario to appear on your exams is severe septicemia due to Neisseria meningitidis infection. Key things to look for are disseminated intravascular coagulation, or DIC, endotoxic shock, petechial rash, and headache with neck stiffness if meningitis is also present. Diagnosis is based on clinical features of adrenal insufficiency, as well as identifying the causative pathogen. If meningitis is suspected, a lumbar puncture is performed to obtain cerebrospinal fluid for analysis and culture. In all other instances, blood cultures should be obtained. Additionally, blood work could show a sudden fall in hemoglobin and hematocrit, leukocytosis and progressive hyperkalemia, hyponatremia, and volume contraction. Remember that DIC will cause thrombocytopenia and extremely elevated PT and PTT, with prothrombin time and partial thromboplastin time suggestive of disseminated intravascular coagulation. Treatment should be focused on correcting fluid, electrolyte, and hematological deficits as well as treating the infection with antibiotics. IV hydrocortisone can be used to address adrenal insufficiency. Okay, let's look at the causes of secondary adrenal insufficiency. The most common is a non-functional pituitary macroadenoma. This type of adenoma is a benign tumor of the pituitary greater than 1 centimeter. If the tumor is large enough, it can compress the normal pituitary tissue. So, in time, some or all of the pituitary hormones become deficient, which is called hypopituitarism. Regarding symptoms, the tumor can cause headaches, and as the tumor compresses on the nearby nerves, visual abnormalities. Individuals can also develop signs of adrenal insufficiency and hypopituitarism. Diagnosis is based on a head MRI to identify the tumor's size and location, and pituitary hormone serum measurements to look for hypopituitarism. Treatment is usually transsphenoidal resection, which is when the tumor is removed through the nose. And finally, the more common tested causes of tertiary adrenal insufficiency are sudden withdrawal of glucocorticoid therapy. Another cause is when a person was treated for Cushing's syndrome, and a tumor secreting ACTH in the pituitary or cortisol in the adrenal gland gets removed. Both glucocorticoid therapy and a tumor secreting cortisol will lead to inhibition of the hypothalamic pituitary adrenal axis and, consequently, decrease natural production of CRH. But when the cause of high cortisol levels is removed suddenly, it can take more than a year for CRH production to go back to normal, resulting in adrenal insufficiency. Diagnosis is based on a combination of history, clinical findings, imaging, and serum cortisol, ACTH, and CRH measurements. Treatment is hormone replacement therapy. Alright, as a quick recap. Adrenal insufficiency can be primary, when the adrenal glands don't work properly, or central, when there's a problem with either the hypothalamus or the pituitary. With primary adrenal insufficiency, there is low cortisol, high ACTH, and no increase in cortisol level after the ACTH stimulation test. There can also be low aldosterone and high plasma renin activity. With central adrenal insufficiency, there is low cortisol and low ACTH, an increase in cortisol after ACTH administration, but no aldosterone deficiency. Central adrenal insufficiency can further be secondary or tertiary. With secondary insufficiency, there's no increase in ACTH after a CRH injection, whereas with tertiary disease, ACTH levels increase after CRH. Causes of primary adrenal insufficiency, or Addison disease, can be autoimmune, when there are anti-adrenal antibodies present, or non-autoimmune, which can happen because of adrenal infections, bilateral adrenal metastases, or hemorrhages. Secondary adrenal insufficiency is usually due to a pituitary tumor or a central nervous system tumor. Finally, tertiary adrenal insufficiency can occur either because of sudden withdrawal of glucocorticoid therapy or after the removal of a tumor causing Cushing's syndrome. Primary insufficiency can cause hyperpigmentation, hypotension, hyperkalemia, and metabolic acidosis. Secondary and tertiary adrenal insufficiency can be associated with headaches, visual abnormalities, and hypopituitarism. Both primary and central adrenal insufficiency can present acutely as an adrenal crisis with symptoms like fever, shock, abdominal pain, and altered mental status. Treatment consists mostly of lifelong hormone replacement therapy. Now, back to our cases. Mike presents with chronic symptoms like fatigue, weight loss, and muscle pain, and a family history of autoimmune diseases. Examination reveals hypotension and skin hyperpigmentation. Together, these symptoms are highly suggestive of primary adrenal insufficiency, most likely from an autoimmune cause given his family history, and the fact that he's from Canada, a high-income country. The diagnosis was partially confirmed by low serum cortisol levels, so the next step would be obtaining serum ACTH, aldosterone, and anti-21-hydroxylase antibody levels, plus an ACTH stimulation test to confirm that the insufficiency is indeed primary. Teresa, on the other hand, presented with acute symptoms like vomiting, abdominal pain, hypotension, and altered mental status. Now, these are rather unspecific, but adding the fact that she underwent transphonoidal resection of a pituitary tumor and her low serum cortisol levels suggests adrenal crisis due to tertiary adrenal insufficiency. A CRH stimulation test would be needed to confirm the diagnosis. She was started on IV fluids and hydrocortisone immediately.
While doing your rounds, you see two individuals. First is Jessica, who comes in with lumbar pain, anuria, and constipation. Examination is unremarkable, and she doesn't have any history of kidney disease. The other person is 38-year-old Dan, who is obese and has an abnormally round face. He is also hypertensive and hyperglycemic. Dan is not taking any medications, but he's complaining of severe lumbar pain on the left side. Abdominal CT scans were obtained for both. In Jessica's case, imaging detected a mass in the right adrenal cortex. In Dan's case, CT detected a mass in the left adrenal cortex. Okay, so both seem to have some type of adrenal masses. But first, a little bit of physiology. Each adrenal gland has two main components, the cortex, and the medulla. For your exam, something high yield to keep in mind is that the cortex is composed of 3 zones. The zona glomerulosa, the outer zone, contains clustered cells that produce mineralocorticoids, mainly aldosterone, which regulates blood pressure and electrolyte balance. The zona fasciculata, the middle zone, contains foamy-looking cells in columns that are responsible for the production of glucocorticoids, predominantly cortisol, which increases blood sugar levels via gluconeogenesis, suppresses the immune system, and aids in metabolism. And the innermost zone is the zona reticularis, which has basophilic cells arranged in anastomosing cords that produce gonadocorticoids, especially androgens like dihydroepiandrosterone or DHEA. The medulla is composed of special cells called chromaffin cells. These are modified postganglionic sympathetic neurons that originate from the neural crest. Normally, when a fetus is in its 5th week of development, special cells called neural crest cells start migrating along the midline of the embryo. In the thoracic region, neural crest cells differentiate into the neurons of the sympathetic chain on either side of the developing spinal cord. In the lumbar region, neural crest cells differentiate into the cells of the adrenal medulla. Chromaffin cells are also responsible for the pulsatile production of catecholamines, like epinephrine, also known as adrenaline, norepinephrine or noradrenaline, and small amounts of dopamine. These hormones prepare the body for the fight or flight response by increasing the heart and respiratory rate, constricting blood vessels, increasing the metabolic rate, and heightening cognitive awareness. Another high-yield fact is that unlike postganglionic sympathetic neurons that release norepinephrine as a neurotransmitter, chromaffin cells release norepinephrine in the bloodstream as a hormone, so it can act on various tissues far from the adrenal glands. Okay, so adrenal masses and tumors can emerge from any cell of the adrenal cortex or medulla that over-proliferates. The tumors can be benign or malignant. And with regard to hormone secretion, these tumors can be non-functional, meaning they don't secrete hormones, or functional, meaning they secrete hormones and cause hormone-specific symptoms. Now, when it comes to non-functional adrenal tumors, the ones in the cortex are typically benign, and most are adenomas. The ones in the medulla, however, are more likely to be carcinomas. One of the main risk factors for adrenal carcinomas is mutations in the TP53 gene, which codes for a tumor suppressor protein. Those with a mutated TP53 gene are at risk of developing Li-Fraumeni syndrome, which is an autosomal dominant disorder that involves multiple malignancies at an early age. The syndrome is also known as SBLA syndrome, which is an acronym given by the malignancies it is associated with: sarcoma, breast cancer, leukemia, and adrenal gland carcinoma. Additionally, adrenal carcinomas may not be primary, meaning they metastasized from elsewhere in the body. These most often come from the lungs, kidney, colon, lymphomas, and skin melanomas. Because non-functional tumors don't secrete any hormones, the symptoms they cause mostly depend on their size and the organs they compress. Many individuals are initially asymptomatic. However, if the tumor involves both glands from the beginning, which is a rare occurrence, it can lead to adrenal insufficiency. Symptoms of adrenal insufficiency can include weight loss, muscle weakness, fatigue, low blood pressure, and darkening of the skin. In time, as the tumor grows, it can start pressing on the nearby structures. These can consist of lumbar pain when the tumor presses on nearby spinal nerves, anuria or non-passage of urine when it compresses on the ureters, and even constipation if the tumor is large enough to block a part of the intestine. One very high-yield complication is rupture of a highly vascularized tumor, which can lead to adrenal hemorrhage. The major signs of adrenal hemorrhage are abdominal pain, falling hematocrit, and signs of an adrenal crisis, including hyponatremia, fever, and loss of consciousness. Additionally, malignant tumors can also cause symptoms like persistent abdominal or flank pain, hematuria, as well as general symptoms like weight loss and anorexia. Adrenal carcinoma can also metastasize to the liver, lungs, lymph nodes, the 3 Ls, as well as the bones, which means individuals might also present symptoms related to the affected organ. Diagnosis of non-functional tumors begins with a CT scan, which can provide some clues regarding the benign versus malignant nature of the tumor, like the size of the mass, its shape, and borders. In some cases, a biopsy should also be performed, especially if imaging cannot characterize the mass as benign and if pheochromocytoma is excluded. Biopsy is also recommended if there's suspicion that the tumors are actually metastases from other sites in the body. If metastases are suspected, CT imaging of the chest and liver, as well as a bone scan, should be done to find the primary tumor. Treatment of benign, non-functional tumors depends on the size. A smaller tumor can be monitored regularly by CT or MRI. A large or potentially malignant tumor should be removed via laparoscopic adrenalectomy. Chemotherapy and radiation therapy are used as needed. Now, when it comes to functional benign and malignant tumors, these are diverse, and the symptoms they cause depend on the type of adrenal cells they derive from. Starting with the outermost zone of the adrenal cortex, the zona glomerulosa, you need to know that the tumors that secrete aldosterone usually originate from this zone, and these tumors are usually benign. Remember that aldosterone release is increased whenever there is a drop in blood pressure or sodium levels. This hormone increases the activity of the sodium-potassium ATPase ion pump on the surface of the cells that line the distal tubules and collecting ducts of the kidney. The result is increased sodium and water reabsorption and increased potassium and hydrogen excretion through urine. When there's a tumor that secretes too much aldosterone, we get Conn syndrome, or primary aldosteronism. The high levels of aldosterone will lead to hypokalemia, hypernatremia, and metabolic alkalosis. In addition, more water is reabsorbed by the kidneys, along with the sodium, so there's also an increase in plasma volume, leading to hypertension. As a result, the main symptom of primary aldosteronism is treatment-resistant hypertension. Now, it might be helpful to know that because hyperaldosteronism also causes potassium loss, the affected individuals might come in with symptoms of hypokalemia, muscular aches and weakness, muscle spasms, numbness, and heart palpitations. Excessive water retention can also lead to increased urination, while metabolic alkalosis is usually associated with nausea, vomiting, and abdominal pain. Something else that might help you is that Conn syndrome does not usually cause edema because of something called an aldosterone escape mechanism. The mechanism is actually unknown, but it is believed that in these individuals, the surge in blood volume stimulates the atria of the heart to release high levels of atrial natriuretic peptide, which leads to compensatory diuresis and escape from edema and severe hypernatremia. This is in contrast with secondary hyperaldosteronism, like in heart failure, where the aldosterone escape mechanism is impaired and edema does occur. Diagnosis is high yield, and it begins by measuring serum potassium levels, which should be low. aldosterone levels, which should be high, and plasma renin activity, which should be low as well, since high blood pressure decreases renin release. Serum sodium can be mildly elevated or normal due to the aldosterone escape mechanism. Once primary aldosteronism is confirmed, an abdominal CT or MRI scan is needed to confirm and locate the aldosterone-producing tumor. Some cases may be treated by removing the tumor with surgery. In case of bilateral tumors, treatment is typically with aldosterone antagonists, such as spironolactone or eplerenone. Other medications for high blood pressure, hypokalemia, and a low-salt diet may also be needed, especially before surgery. Next, the tumors that secrete cortisol typically originate in the cells of the zona fasciculata. These are more often adenomas, but in rarer cases, carcinomas can also secrete cortisol. High cortisol level causes Cushing syndrome. Now, Cushing syndrome can be caused by anything that leads to excess cortisol, not only by adrenal tumors. A high-yield fact to keep in mind is that the majority of cases actually occur in individuals using exogenous cortisol, like prednisone, over a long period of time, often as a treatment for autoimmune and inflammatory conditions, like rheumatoid arthritis or poorly controlled asthma. Whatever the cause, high cortisol levels trigger the negative feedback in the hypothalamus, which suppresses corticotropin-releasing hormone, or CRH, production. This suppresses adrenocorticotropic hormone, or ACTH, production by the pituitary. Normally, at this point, with nothing to stimulate them, the adrenal glands would stop producing cortisol. However, tumors secreting cortisol are not regulated by ACTH, so they keep pumping out cortisol independently. In contrast, with no stimulation from ACTH, the normal tissue in the zona fasciculata of the uninvolved adrenal gland shrinks and atrophies. The symptoms of Cushing syndrome are directly related to the effects of excess cortisol on its various target tissues. For example, excess cortisol leads to severe muscle and skin breakdown, which leads to muscle wasting, skin thinning, abdominal striae or lines, and easy bruising. The bones are also broken down, so fractures can occur due to osteoporosis. Next, there's elevated blood glucose level due to increased gluconeogenesis in the liver. As a result, insulin level goes up, and eventually, insulin resistance develops. Cortisol also increases appetite, which can lead to weight gain, which can manifest as truncal obesity. But there's also fat redistribution to the cheeks, resulting in a round, moon-shaped face, and to the back of the neck, causing buffalo hump. Cushing syndrome can also lead to arterial hypertension. That's because cortisol can amplify the effect of catecholamines on blood vessels. Cortisol is also a weak agonist for mineralocorticoid receptors, so it can increase blood pressure by causing the kidneys to retain more fluid and sodium. Remember for your exam that this is called pseudo-hyperaldosteronism. High levels of cortisol also inhibits the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. In females, this leads to amenorrhea or absent menstruation. Diagnosis of Cushing syndrome caused by an adrenal tumor is a simple algorithm that's very high yield. It's initially based on measuring the free cortisol in a 24-hour urine sample to confirm cortisol levels are high. Alternatively, blood or saliva tests at midnight can help check if there's a normal daily rise and fall of cortisol levels. Moving on, we need to test the ACTH plasma level. In adrenal tumors, it's important to know that ACTH levels are usually low because high levels of cortisol inhibit the pituitary secretion of ACTH. The next step is the overnight low-dose dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in ACTH and serum cortisol levels by morning. But if Cushing syndrome is caused by endogenous cortisol production, then the serum cortisol levels should remain unchanged. And finally, an abdominal CT or MRI might help locate and differentiate a benign tumor from a malignant one. Treatment consists of removing the tumor surgically. Sometimes, medication can be given before or after surgery, or as an alternative when surgery is not possible. The antifungal ketoconazole, which acts as an adrenal steroidogenesis inhibitor, is the most commonly used drug for Cushing syndrome, mainly because of its rapid action. The glucocorticoid receptor antagonist mifepristone is also effective in controlling clinical morbidities, mainly glucose intolerance. Now let's switch to tumors of the medulla. These are usually neuroendocrine tumors, which are a group of tumors that can occur in almost any endocrine or non-endocrine tissue, especially in the gut, pancreas, lungs, and adrenal glands. In essence, they are made up of cells that have traits similar to those of nerve cells and hormone-producing cells, which is why they can produce pretty much any type of hormone. Just like most tumors, they can be functional or non-functional, and of course, benign or malignant. They are sporadic, but can also be seen in several inherited familial syndromes, including multiple endocrine neoplasia type 1 and 2, von Hippel-Lindau disease, and neurofibromatosis type 1. One particular neuroendocrine tumor that's most often found in the adrenal gland is pheochromocytoma, a tumor that is derived from chromaffin cells and secretes catecholamines, like epinephrine and norepinephrine. Pheochromocytomas are usually benign, and it's the most common tumor of the adult adrenal medulla. Something that can help you remember the high-yield facts about this tumor is the rule of 10, which is called that because around 10% of pheochromocytomas are malignant, bilateral, extraadrenal, most commonly in the bladder, calcify, and occur in kids. Although they tend to arise sporadically, 10% of pheochromocytomas are associated with inherited syndromes. For example, there are two syndromes called multiple endocrine neoplasia type 2A and type 2B, where there are multiple tumors, including pheochromocytoma, usually caused by a mutation in the RET gene, which has a role in cell growth and division. Another disease associated with pheochromocytomas is von Hippel-Lindau disease, which develops when there's a mutation in the VHL gene of the chromosome 3p, which codes for the von Hippel-Lindau tumor suppressor protein. A third disease is neurofibromatosis type 1, or Recklinghausen disease, which is caused by a mutation in the gene NF1, located on chromosome 17, that encodes for another tumor suppressor protein called neurofibromin. Regardless of its cause, remember that once pheochromocytomas develop, they cause symptoms by releasing too much epinephrine, norepinephrine, and sometimes dopamine into the blood, which triggers a spell or an episode of hyperadrenergic symptoms. This often occurs in situations of stress and physical exertion, where the sympathetic nervous system increases the release of catecholamines. It can also occur upon ingesting certain foods, like chocolate, cheese, and wine, which contain tyramine, a substance that triggers the release of catecholamines. Once released into the bloodstream, catecholamines cause the smooth muscles around blood vessels to contract, raising the peripheral vascular resistance, resulting in hypertension that can't be controlled with antihypertensive medication. During a spell, the blood pressure can go over 180/120 millimeters of mercury, and this is called hypertensive urgency. This can cause damage to the smaller vessels in organs, leading to hemorrhage and ischemia. When there's organ damage, it's called malignant hypertension. Organs that are more sensitive to ischemia or require a larger blood supply are affected first. So common complications include retinal damage, ischemic or hemorrhagic stroke, kidney failure, and myocardial infarction or heart failure. Besides hypertension, the excess catecholamines can also cause sympathetic overactivation, leading to symptoms like anxiety, pallor, tremors, headaches, tachycardia, sweating or diaphoresis, chest pain, and palpitations. In some cases, individuals can also develop a paraneoplastic syndrome called secondary polycythemia, where the tumor also secretes erythropoietin. Excess erythropoietin leads to red blood cell overproduction, which makes the blood thicker, harder to pump, and easier to clot. Finally, in the rare case of malignant pheochromocytoma, the tumor can metastasize, most commonly to lymph nodes, liver, bones, and lungs, and cause organ-specific symptoms. Diagnosis is made by CT and MRI and by checking the levels of two hormones, metanephrine and normetanephrine, which are compounds that come from the degradation of catecholamines in the blood and in the urine. This can be done by either a plasma-free metanephrines test or by a 24-hour urinary metanephrines test. Catecholamine levels can also be measured in the urine and plasma, although these methods are less accurate. Once we know there's a pheochromocytoma, an ultrasound or a CT scan can be used to look for the location of the tumor. For treatment, the goal is to remove the tumor surgically. However, you need to know that blood pressure needs to be lowered prior to surgery to prevent a hypertensive crisis. This is done by alpha blockade, which is achieved by giving irreversible alpha blockers such as phenoxybenzamine, and it should always be followed and not preceded by beta blockade, which is achieved with beta blockers such as propranolol. Another important neuroendocrine tumor that often affects the adrenal glands is neuroblastoma. This is a type of cancer, and it is the most common adrenal medulla tumor in infants and children under 4. Neuroblastoma is composed of poorly differentiated neuroblasts, which also originate from the neural crest, and they can occur anywhere along the sympathetic chain and the adrenal glands. And although the causes of neuroblastoma are unknown, the tumor is associated with amplification of N-MYC oncogene. Now, just like pheochromocytoma, neuroblastomas produce catecholamines, especially norepinephrine and dopamine. However, they do not typically cause severe hypertension, because these tumors do not usually secrete the more potent epinephrine. Some of the symptoms of neuroblastoma can result from the tumor-releasing inflammatory chemokines that cause fever, weight loss, sweating, and fatigue. Other symptoms of neuroblastoma depend on where the tumor is located and are usually a result of the tumor pressing up against surrounding organs. For example, thoracic tumor that extends to the neck can compress the cervical ganglion, causing Horner syndrome. Horner syndrome involves meiosis or constriction of the pupils, ptosis or drooping of the eyelid, and anhidrosis, which is an inability to sweat. Children with neuroblastoma of the adrenal medulla can have a large, painful abdominal mass that causes abdominal distension. Now, a pediatric kidney cancer called Wilms tumor can also have a similar presentation. So remember that when a neuroblastoma grows large enough, it will often cross the midline, but a Wilms tumor typically won't. About half of all neuroblastomas spread to the bones, causing bone pain and small fractures. With the secretion of catecholamines, There might also be mild hypertension, although it's not nearly as severe as in pheochromocytoma. Sometimes there might be a paraneoplastic syndrome called the opsoclonus-myoclonus ataxia syndrome or dancing eye syndrome. This is a serious, rare, and often chronic neurological disorder consisting of three main symptoms. Opsoclonus, which are multidirectional chaotic eye movements, myoclonus, which are non-epileptic limb jerkings that can also involve the head and face, and truncal ataxia, which causes gait imbalance. This is another key clue that could help you differentiate neuroblastoma from Wilms tumor. Diagnosis of neuroblastoma usually starts with testing for epinephrine and norepinephrine metabolites like homovanillic acid or HVA and vanillyl mandelic acid or VMA in the blood or urine. An abdominal CT scan can be used to show the location and size of the tumor. Sometimes a biopsy might be necessary, which typically shows dark tumor cells arranged in Homer-Wright rosettes, which are characteristic of neuroblastoma and medulloblastoma. The rosettes are composed of a single layer of dark cells in a halo or spoken wheel arrangement surrounding a pale core. These cells also stain positive for bombesin, neurofilament, and neuron-specific enolase, which are markers associated with neuroendocrine tumors. Treatment largely depends on the size and staging of the neuroblastoma. Early on, surgery can be used to remove the tumor, but once it starts to metastasize, it will require a combination of chemotherapy, radiotherapy, medication, and even a stem cell or bone marrow transplantation. Alright, as a quick recap, tumors in the adrenal glands can be functional or non-functional. The functional tumors that secrete aldosterone originate from the cells of the zona glomerulosa, and they cause Conn syndrome. Excess aldosterone leads to hypokalemia, hypernatremia, metabolic alkalosis, and hypertension. When it comes to tumors that secrete cortisol, they typically originate in the cells of the zona fasciculata, and they cause Cushing syndrome. Common symptoms include weight gain, moon facies, buffalo hump, skin striae and thinning, and amenorrhea. Complications include osteoporosis, hypertension, and diabetes. Common neuroendocrine tumors include pheochromocytoma and neuroblastoma. Pheochromocytomas are typically benign, and they release epinephrine and norepinephrine, which leads to severe hypertension. Neuroblastomas are a cancer of the adrenal medulla that's mainly seen in children and infants. They secrete norepinephrine and dopamine, but not epinephrine. So while they also cause hypertension, it's not as severe as those seen in pheochromocytoma. They can grow very large, causing a palpable, painful abdominal mass, and even abdominal distension. Going back to our cases, Jessica came in with lumbar pain, anuria, and constipation. Examination was unremarkable, and she doesn't have any history of kidney disease. Her symptoms are rather nonspecific, which is why an abdominal CT was obtained. The CT scan showed a tumor in her right adrenal gland. The tumor is also non-functional since Jessica doesn't appear to have any symptoms to suggest hormone excess. Dan, on the other hand, is obese, has an abnormally round face, and he is hypertensive and hyperglycemic, which are symptoms consistent with Cushing syndrome. The fact that Dan is not taking any medications, but he's complaining of severe lumbar pain on the left side, makes us think the excess cortisol causing his symptoms is due to an adrenal tumor rather than exogenous cortisol ingestion. This was actually confirmed by an abdominal CT, which showed a tumor in his left adrenal gland. To confirm the tumor is functional, we need to measure the level of free cortisol in a 24-hour urine sample and perform a dexamethasone suppression test.
On the endocrinology ward, 2 people came in with similar symptoms. One of them is 45-year-old Samantha, who complains of gaining a lot of weight lately. Samantha also suffers from severe asthma, for which she's taking oral glucocorticoids. She's also had many viral and bacterial infections of late. On clinical examination, there's truncal obesity, a large hump behind her neck, and striae on her abdomen. Her arterial pressure was elevated, and she also had hyperglycemia. The other person is 38-year-old Dan, who's also obese and has an abnormally round face. He has arterial hypertension and hyperglycemia. Unlike Samantha, Dan is not taking any medications. A 24-hour urine-free cortisol was done in both individuals and their levels were high. Further investigations were done, including ACTH levels. Now, both individuals suffer from an endocrine disorder that involve high levels of cortisol. This is generally called Cushing's syndrome. Now, if Cushing's syndrome results from a pituitary adenoma making excess ACTH, it's called Cushing disease. Normally, the hypothalamus secretes corticotropin-releasing hormone, known as CRH, which stimulates the pituitary gland to secrete adrenocorticotropic hormone, known as ACTH. ACTH travels to the adrenal glands, where it targets cells in the adrenal cortex. The adrenal cortex is the outer part of the adrenal gland and is subdivided into 3 layers: the zona glomerulosa, the zona fasciculata, and the zona reticularis. Zona fasciculata is the middle zone and also the widest, and ACTH specifically stimulates cells in this zone to secrete cortisol. This is a class of steroids, or lipid-soluble hormones, called glucocorticoids. Glucocorticoids are not soluble in water, so most cortisol in the blood is bound to a special carrier protein, and only about 5% is unbound or free. In fact, only this small fraction of free cortisol is biologically active, and its levels are carefully controlled. Excess free cortisol is filtered in kidneys and dumped into the urine. Free cortisol in the blood is involved in a number of things, and it's part of the circadian rhythm. Cortisol levels peak in the morning, when the body knows we need to get up and go, and then drop in the evening, when we're preparing for sleep. In times of stress, cortisol increases gluconeogenesis, proteolysis, and lipolysis. Cortisol also helps maintain blood pressure by increasing the sensitivity of peripheral blood vessels to catecholamines, which further cause vasoconstriction. Cortisol helps to dampen the inflammatory and immune response by reducing the production and release of inflammatory mediators, as well as inhibiting the proliferation of T lymphocytes. Finally, cortisol receptors are present in the brain, where their full effect is still actually unclear but might influence things like mood and memory. For all this to work properly, though, the levels of free cortisol have to stay within the normal range. To do that, the body uses negative feedback, which means that high levels of cortisol tell the hypothalamus and pituitary gland to decrease their secretion of CRH and ACTH respectively. Less CRH also tells the pituitary to make less ACTH, so the pituitary ends up having 2 reasons not to make ACTH. With less ACTH floating around, the zona fasciculata gets less stimulation to make cortisol, and eventually, cortisol levels go back down to the normal range again. Okay, now Cushing's syndrome can be caused by exogenous cortisol used as medications or endogenous cortisol, meaning that the excess cortisol is made by the body. A very high-yield fact is that the majority of cases of Cushing's syndrome occur in individuals using exogenous cortisol, like prednisone, over a long period of time, often as a treatment for autoimmune and inflammatory conditions, like rheumatoid arthritis or poorly controlled asthma. They have structures similar to endogenous cortisol and mimic its actions in various tissues. In fact, exogenous cortisol can also cause negative feedback on the hypothalamus and the pituitary gland, leading to a decrease in CRH and ACTH, which in turn shuts down cortisol production from the zona fasciculata. Over time, this lack of stimulation can cause zona fasciculata of both adrenal glands to physically shrink or become atrophic. Even though this results in less endogenous cortisol production, it still doesn't quite compensate for the huge levels of exogenous cortisol, and that causes Cushing's syndrome to develop. Now, if the medication is stopped abruptly, the atrophied adrenal glands can't produce enough cortisol, so we get adrenal insufficiency. If the cortisol level is low enough, it might trigger an adrenal crisis. This is a life-threatening condition with symptoms like fever, hypotension, severe abdominal pain with vomiting and diarrhea, confusion, psychosis, and coma. In addition to taking exogenous steroid medications, Cushing's syndrome can also result from increased levels of endogenous cortisol. The most common cause is Cushing disease, where the pituitary releases too much ACTH. For your exams, remember the leading cause is a pituitary adenoma, which is a benign tumor of the pituitary gland. The exact reason for the development of this sort of benign tumor isn't known, and the pituitary adenoma simply grows in size and secretes excess ACTH. This causes the zona fasciculata of both adrenal glands to undergo hyperplasia and secrete excess cortisol. Apart from pituitary adenomas, there are ectopic sources of ACTH, such as paraneoplastic syndromes. The high-yield ones to remember are small cell lung cancer and bronchial carcinoids. In these cases, the excess ACTH is coming from somewhere other than the pituitary, so these cases are not considered Cushing disease. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas, which are benign tumors, and adrenal carcinomas, which are malignant tumors. In both adrenal adenomas and carcinomas, the cells of the zona fasciculata within the adrenal cortex start dividing abnormally and secrete excess cortisol. As before, the excess cortisol provides negative feedback to the hypothalamus and pituitary gland, suppressing CRH and ACTH production. This doesn't have any effect on zona fasciculata of the involved adrenal gland, since the neoplastic cells are autonomous, meaning that they grow independently from ACTH. However, the zona fasciculata of the uninvolved adrenal gland shrinks and atrophies. This could be a clue to help you narrow down the cause to the adrenal gland. The net result, though, is abnormally high levels of cortisol, and that causes Cushing syndrome. Regardless of the cause, the symptoms of Cushing syndrome are directly related to the effects of excess cortisol and other glucocorticoids on its various target tissues. Since cortisol levels are elevated chronically, its effects will be exaggerated. Excess cortisol leads to severe muscle and skin breakdown, which are major sources of protein in the body. This leads to muscle wasting and thin extremities, skin thinning, easy bruising, and abdominal striae or lines. The bones are also broken down for calcium, so fractures can occur due to osteoporosis. Next, there's elevated blood glucose level due to increased gluconeogenesis in the liver. As a result, insulin level goes up, and eventually insulin resistance develops. Cortisol also increases appetite, which can lead to weight gain. This can manifest as truncal obesity, but there's also fat redistribution to the cheeks, resulting in a round, moon-shaped face, and to the back of the neck, causing buffalo hump. Cushing syndrome can also lead to arterial hypertension. That's because cortisol can amplify the effect of catecholamines on blood vessels. Second, cortisol is a weak agonist for mineralocorticoid receptors, so it can act like a weaker version of aldosterone and increase blood pressure by causing the kidneys to retain more fluid and sodium. Remember for your exam that this is called pseudohyperaldosteronism. High levels of cortisol also inhibit the secretion of gonadotropin-releasing hormone from the hypothalamus, which messes up normal ovarian and testicular function. In females, this leads to amenorrhea. Now, in cases with high levels of ACTH, such as Cushing disease, ACTH can also stimulate the production of androgen hormones, leading to hirsutism in females. Excess cortisol also dampens the inflammatory and immune response, making individuals develop a form of immunosuppression, making them more susceptible to infections. Finally, High levels of cortisol seem to impair normal brain function, but the exact mechanism is unclear. Diagnosis of Cushing's syndrome is a simple algorithm that's very high yield. It's initially based on measuring the free cortisol in a 24-hour urine sample to confirm cortisol levels are high. Alternatively, blood or saliva tests at midnight can help check if there's a normal daily rise and fall of cortisol levels. Another option is also the dexamethasone suppression test, which is when a person is given a low dose of dexamethasone, which is an exogenous steroid that suppresses ACTH production in the pituitary gland. Normally, that should cause a decrease in serum cortisol levels. But if Cushing's syndrome is caused by endogenous cortisol production, then the serum cortisol levels should remain unchanged. If that test is positive, the next step is to determine the exact cause of endogenous cortisol production, and ACTH plasma levels can be checked. Low ACTH levels can be seen in adrenal adenomas, adrenal carcinomas, and exogenous glucocorticoids, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step is to give an injection of a high dose of dexamethasone, and this is called a high-dose dexamethasone suppression test. If there's no suppression, and the ACTH level remains the same, it means there's an ectopic site of ACTH productions, in which case a CT of the chest, abdomen, and pelvis can be done in order to find the source. If levels of ACTH fall after the high-dose dexamethasone test, then this means it's Cushing disease, in which case an MRI of the pituitary is done to confirm. An alternative to the high-dose dexamethasone suppression test is the CRH stimulation test, where an individual is given synthetic CRH. Now, if there's no rise in ACTH and cortisol after the test, then this means ACTH secretion is ectopic. And just as before, a CT scan of the chest, abdomen, and pelvis are done. If there's a rise in ACTH and cortisol, then this means the pituitary responds to CRH, and we're talking about Cushing disease, in which case an MRI of the pituitary is done. Alright, as a quick recap, Cushing syndrome is a set of symptoms caused by high levels of glucocorticoids. The most common source is an exogenous cortisol like prednisone, but it could also be caused by endogenous cortisol production within the body. Steroid medication can cause negative feedback in the hypothalamus and the pituitary glands, leading to a decrease in CRH and ACTH, which in turn shuts down cortisol production. Over time, both adrenal glands can become atrophic. In case of endogenous cortisol, the most common cause is excess ACTH that usually happens due to a pituitary adenoma, and this is referred to as Cushing disease. The excess ACTH causes both adrenal glands to undergo hyperplasia. Apart from pituitary adenomas, there are ectopic sources of ACTH, like paraneoplastic syndromes associated with small cell lung cancer or bronchial carcinoids. Another common cause of endogenous Cushing syndrome is tumors of the adrenal glands that make excess cortisol, like adrenal adenomas or adrenal carcinomas, and in this case, CRH and ACTH production are suppressed and the normal adrenal gland atrophies. Symptoms of Cushing syndrome include arterial hypertension, weight gain, and truncal obesity, moon face, buffalo hump, thinning and striae on the skin, hirsutism, osteoporosis, hyperglycemia, amenorrhea, and immunosuppression. Diagnosis of Cushing syndrome is based on a high 24-hour urine-free cortisol test, a high late-night salivary test, or inadequate suppression on the dexamethasone suppression test. Next to identifying the cause, ACTH levels are taken. Low ACTH levels can be seen in adrenal adenomas, adrenal carcinomas, and exogenous glucocorticoids, whereas high ACTH levels can be seen in Cushing disease and ectopic ACTH production. If the ACTH level is high, the next step to do is a high-dose dexamethasone suppression test. If there's no suppression, then this means there's an ectopic site of ACTH productions, in which case a CT of the chest, abdomen, and pelvis can be done in order to find the primary tumor. If levels of ACTH fall after the high-dose dexamethasone test, then this means it's Cushing disease, in which case an MRI of the pituitary is done to confirm. Now back to our cases. Samantha came in with arterial hypertension, truncal obesity, a buffalo hump, striae on the abdomen, and hyperglycemia. All of these are signs and symptoms of Cushing syndrome. The cause is most likely the glucocorticoid she's been taking for her asthma. This decreased her immune response, which is the cause of the repeated viral and bacterial infections. A 24-hour urine-free cortisol was done, and levels were high. Furthermore, ACTH levels were low, meaning that cortisol secretion is independent of ACTH. This confirms the diagnosis of Cushing syndrome caused by exogenous glucocorticoids. Now, Dan came in with similar symptoms as Samantha, but he didn't have a history of glucocorticoid use. Tests showed high levels of urine-free cortisol, but this time, levels of ACTH were high, and high-dose dexamethasone suppression test was done, and this showed adequate suppression of ACTH levels. This means that Dan most likely has a pituitary adenoma, which is responsible for the high levels of cortisol and ACTH. When a pituitary adenoma is the cause of Cushing syndrome, we call this Cushing disease. An MRI of the pituitary will be done to confirm the diagnosis.
Okay, so 2 people were admitted to the endocrinology ward. One of them is 35-year-old Imre, who came in with intense polyuria and polydipsia. Imre was dehydrated and presented with dry mouth, headache, dry skin, and dizziness. Several tests were done, and results showed increased serum osmolality, and further on, a desmopressin test was done. During the test, an ADH analog was administered and urine osmolality increased. The other person is 45-year-old Sienna, who came in to do some routine tests because she started taking cyclophosphamide and wanted to make sure that there were no complications. Her lab results showed hyponatremia, decreased blood osmolality, and her urine osmolality was higher than serum osmolality. Now, both individuals are unable to maintain normal osmolality, but to understand this, we need to go over a bit of physiology first. In the brain, specifically in the hypothalamus, there are osmoreceptors, which can sense the osmolality of the blood, or how concentrated it is. Osmolality is the concentration of dissolved particles in the blood plasma, or the liquid portion of blood. There are a number of dissolved particles in the blood plasma, but the major ones are glucose, sodium, and blood urea nitrogen, and a normal osmolality is between 285 and 295 milliosmoles per kilogram. Now, during periods of dehydration, there is an increase in concentration of these particles in the blood, and osmolality increases. The osmoreceptors in the hypothalamus sense the change in osmolality, and this triggers the sensation of thirst. The water that we drink gets absorbed and dilutes the blood, bringing the osmolality back to normal. In addition to osmoreceptors, the hypothalamus also contains the supraoptic and paraventricular nuclei that produce antidiuretic hormone, or ADH, which is then sent to the posterior pituitary for storage. ADH is also called vasopressin because it causes smooth muscle around the blood vessels to contract, which increases resistance and raises blood pressure. When the osmoreceptors detect high osmolality, they signal the supraoptic nucleus to send ADH into the blood, which travels to the kidneys, specifically to the principal cells in the distal convoluted tubule, and the collecting ducts of the nephrons. Here, ADH binds to a receptor called vasopressin receptor 2, or VR2. This causes aquaporin proteins inside the principal cells to embed into the cell membrane and open a channel that only lets water from the lumen of the nephron back into the blood. Just like drinking more water, this dilutes the blood and returns plasma osmolality to a normal level. However, this reabsorption process also decides how much water leaves the body as urine and how concentrated the urine is, which is one of the things that keeps a normal urine osmolality between 300 and 900 milliosmoles per kilogram. Now that we know all this, diabetes insipidus is when the kidneys reabsorb too little water, so the water remains in the nephrons and is lost via urine. This leads to a lot of dilute urine, or polyuria. Since there's less water in the blood, plasma osmolality increases, and that triggers thirst and polydipsia. Now, if the problem is caused by a lack of ADH, it's called central diabetes insipidus. If it's due to a decreased response to ADH by the kidneys, it's called nephrogenic diabetes. Let's start with central diabetes insipidus, which can be caused by conditions that affect the hypothalamus, in which case it won't be able to produce ADH, or conditions that affect the pituitary gland, in which case there's no place to store the ADH, and in some cases, both the hypothalamus and the pituitary gland are affected. As a result, there's insufficient ADH in the blood, and that means there is less vasoconstriction and insufficient aquaporins in the distal convoluted tubule and collecting duct. Some causes of central diabetes insipidus include pituitary tumors, head trauma, head surgery, ischemic encephalopathy, autoimmune conditions, or sometimes the cause can be idiopathic. Then there's nephrogenic diabetes insipidus, which is when there's a problem with the kidneys themselves, which makes them unresponsive to ADH. A high-yield fact is that this is often due to a hereditary genetic defect of the vasopressin receptors or aquaporin proteins. Both of these lead to nephrons that are unresponsive to ADH. In addition, there are medications like lithium that can decrease the production of aquaporin proteins in the collecting duct. Sometimes, nephrogenic diabetes insipidus can be caused by hypokalemia. That's because the aquaporins can degrade in the early phases of hypokalemia. Sometimes, nephrogenic diabetes can also be secondary to hypercalcemia through an unclear mechanism. Finally, democlocycline, which is an ADH antagonist, can block the vasopressin receptors, leading to nephrogenic diabetes insipidus. Now, the symptoms of both central and nephrogenic diabetes insipidus are polyuria and polydipsia, and you have to remember this for your tests. A person with diabetes insipidus typically produces over 3 liters of dilute urine each day, so it can quickly lead to dehydration and hypotension. This increase in plasma osmolality can result in fatigue, nausea, poor concentration, or confusion. The diagnosis of diabetes insipidus starts with a blood osmolality test, which would show an increased blood osmolality of above 290 milliosmoles per kilogram in both central and nephrogenic diabetes insipidus. The urine-specific gravity is lower than 1006, meaning the kidneys aren't able to properly concentrate urine. There's also hyperosmotic volume contraction. This means that there's decreased extracellular fluid in the body, and the remaining fluid is hyperosmotic, since the water is lost, but the solutes remain. Okay, the way to differentiate central and nephrogenic diabetes insipidus is to look at the ADH level. With central diabetes insipidus, there's low ADH, while with nephrogenic diabetes insipidus, ADH is normal or high. Remember this, as it's a very high-yield concept. In addition, a water deprivation test can be done to distinguish diabetes insipidus from psychogenic polydipsia, which is when an individual drinks more water than they need because of a variety of psychological or psychiatric causes. That test is where an individual doesn't drink water for 2 to 3 hours. Then hourly measurements of urine volume and osmolality are done. In a person with diabetes insipidus, urine osmolality will normally stay below 300 milliosmoles per kilogram despite having no fluid intake. With psychogenic polydipsia, urine osmolality increases during the test. If diabetes insipidus is confirmed, the second step is to administer an ADH analog like desmopressin, which is a medication that works like ADH. If urine osmolality increases about 50% from the baseline value, and remember this number for your exams, by the way, that suggests that the kidneys are responsive to ADH. This means the cause is probably central diabetes insipidus, meaning it's due to low levels of ADH. If the ADH analog causes urine osmolality to increase only slightly, then the kidneys are not responding to the ADH properly, meaning that it's nephrogenic diabetes insipidus. Treatment of central diabetes insipidus relies on desmopressin and proper hydration. Treatment of nephrogenic diabetes insipidus relies on thiazide-like diuretics, like hydrochlorothiazide, which are given to increase urine excretion of sodium. Since sodium contributes to blood osmolality, getting rid of sodium reduces blood osmolality and stops the hypothalamus from triggering thirst. Other options include a potassium-sparing diuretic like amiloride, and this can be used together with thiazide diuretics. Besides diuretics, other options include indomethacin and dietary measures like hydration, dietary salt restriction, and avoidance of medications that can harm the kidneys, like aminoglycosides, for example. Now, we'll be moving on to talk about the syndrome of inappropriate antidiuretic hormone secretion, or SIADH for short. SIADH is a condition where the body makes way too much ADH, as opposed to diabetes insipidus, where there isn't any ADH or where the kidney doesn't respond to it. Okay, SIADH can be caused by several conditions. One of them is ectopic ADH secretion from a tumor outside the hypothalamus or pituitary. This is called paraneoplastic syndrome, and it can be associated with small cell lung carcinoma. Other causes include central nervous system surgery or head trauma that can cause ADH to be released from the damaged pituitary gland. Pulmonary diseases such as pneumonia and chronic obstructive pulmonary disease, or COPD, can lead to SIADH, but the exact mechanism there is unknown. Finally, SIADH can be caused by medications like cyclophosphamide, which increases the number of ADH receptors on principal cells. Now, with SIADH, the increased ADH leads to increased water reabsorption in the kidneys. Water retention leads to an expansion of the extracellular fluid. Some of this water will move into the intracellular fluid. However, there will be a lot of water left in the extracellular fluid, leading to volume expansion. Increased water in the extracellular fluid leads to dilutional hyponatremia, meaning the total sodium level is actually normal, but the sodium is distributed into a larger volume of water. This causes a particular type of hyponatremia called euvolemic hyponatremia, and since it's euvolemic, there's no edema on clinical examination. Volume expansion also increases blood volume and pressure, causing the heart to release atrial natriuretic peptide, or ANP, and brain natriuretic peptide, or BNP. And yes, I know what you're thinking, but despite the name, BNP is also released by the heart. Both of these will dilate the blood vessels to decrease blood pressure, and they also increase glomerular filtration rate. The result is more water and sodium are filtered out and excreted via urine. Next, increased blood flow to the kidneys will reduce renin release, which means there's decreased angiotensin II and aldosterone. Aldosterone normally acts on the distal convoluted tubule and collecting ducts to increase sodium and water reabsorption. So when this hormone is low, we are getting rid of more water, but also even more sodium through urine. Now, if there's severe hyponatremia, more water will move inside cells due to osmosis. The most dangerous complication of this is cerebral edema and seizures. For diagnosis, remember that people with SIADH will have hyponatremia, decreased serum osmolality, and increased urine osmolality. For treatment, the first step is fluid restriction, and this is very high yield. After that, salt tablets and IV hypertonic saline can help correct hyponatremia. Diuretics to excrete the extra water and medications that antagonize the vasopressin receptor, such as tolvaptan, conivaptan, and demococycline, are also given. Now, keep in mind that hyponatremia should be corrected slowly in order to prevent osmotic demyelination syndrome with severe neurological consequences. Alright, as a quick recap. Diabetes insipidus can be central, in which case there's a problem in the hypothalamus or pituitary gland resulting in decreased ADH production or release. Diabetes insipidus can also be nephrogenic, in which case there's a problem with the kidneys themselves, and they are unresponsive to ADH. Symptoms of both central and nephrogenic diabetes insipidus include polyuria and polydipsia. The diagnosis of diabetes insipidus is based on blood osmolality over 290 milliosmoles per kilogram in both central and nephrogenic diabetes insipidus. The urine-specific gravity is lower than 1006, and there's also hyperosmotic volume contraction. With central diabetes insipidus, there's low ADH, while with nephrogenic diabetes insipidus, ADH is normal or high. During a desmopressin test, a large increase in urine osmolality means there's central diabetes insipidus, and a small increase means there's nephrogenic diabetes insipidus. With SIADH, there's excess production of ADH, euvolemic hyponatremia, excessive free water retention, which causes concentrated urine, and decreased serum osmolality. Now, back to our cases. Imre came in with intense polyuria and polydipsia, and tests showed increased serum osmolality, and a desmopressin test was done during which urine osmolality increased when an ADH analog was given. ADH levels were also done, and they were low. Based on symptoms and test results, we can diagnose Imre with central diabetes insipidus, in which case treatment involves desmopressin and hydration. But further investigations will need to be done in order to find the cause. Sienna came in for routine tests, because she's taking cyclophosphamide. Her tests showed hyponatremia, decreased blood osmolality, and increased urine osmolality, and all three of those are found in SIADH. The likely cause is her medication, which increases the number of ADH receptors in the kidneys. Treatment involves fluid restriction and salt tablets.
A 27-year-old female named Clara comes to the clinic complaining of abdominal pain and watery diarrhea, which started 3 months ago. Since then, Clara has also noticed that from time to time, the skin of her face and neck suddenly turns red and feels warm, especially when she drinks alcohol or gets angry. On clinical examination, you notice that both Clara's legs and feet look swollen. Next, you run a urine test, which shows an increased level of 5-hydroxyindolacetic acid. You then decide to order a CT scan, which reveals a large mass in the appendix, along with several smaller masses involving the liver. Some days later, you see a 65-year-old male named William, who came in complaining of heartburn and abdominal pain for the past few months. He also states that his stools are often greasy and foul-smelling. Upon further questioning, William mentions that lately he's lost around 15 kilograms or 33 pounds, although he hasn't been exercising or dieting at all. The first thing you do is run a blood test, which reveals a serum gastrin level of 1,400 picograms per milliliter. Then, you decide to perform an upper gastrointestinal endoscopy, during which you observe multiple ulcers in the stomach, duodenum, and jejunum. Okay, based on the initial presentation, both Clara and William seem to have some form of neuroendocrine tumor of the gastrointestinal system. These tumors arise from neuroendocrine cells, which are most abundant in the epithelial layer of gastrointestinal tract. Other common locations are the thyroid gland, with medullary thyroid cancer, the lungs, where small cell carcinoma can occur, and the medulla of the adrenal gland, which can give rise to pheochromocytoma. Neuroendocrine cells get their name from the fact that they're activated like neurons, since they can receive input from neurotransmitters released by other neurons, but they respond like endocrine cells by releasing hormones into the bloodstream. In a test question, neuroendocrine cells can also be called APUD cells, which stands for amine precursor uptake decarboxylase cells. That's because they can take up certain substances called amine precursors, such as DOPA and 5-hydroxytryptophan, and use an enzyme called decarboxylase to convert them to certain amine hormones, such as dopamine and serotonin. Now, diagnosis of neuroendocrine tumors commonly involves blood or urine tests to measure the levels of hormones or their byproducts. In addition, imaging techniques can help identify the tumor and estimate its size. Diagnosis is confirmed with a biopsy, which will show a rosette-like pattern. This consists of small, uniform, round blue cells that are arranged peripherally around the central lumen. In addition, immunohistochemical stains can be used on the biopsy to detect specific neuroendocrine markers or molecules that are unique to neuroendocrine cells. Some high-yield markers you may find on a test question are chromogranin A, calcitonin, neuron-specific enolase, and synaptophysin. All right, let's now take a deeper dive into some of the most high-yield neuroendocrine tumors of the gastrointestinal tract. These include carcinoid tumors and pancreatic islet cell tumors. Okay, let's start with carcinoid tumors, which most commonly arise in the small intestine, and especially in the ileum, followed by the rectum. The third most common location is the appendix, but keep in mind that this is the one the examiners love the most. And a rare but frequently tested extraintestinal location are the lungs. Now, the carcinoid tumor cells typically secrete serotonin, histamine, and bradykinin. For your exams, remember that when a carcinoid tumor is located in the intestine, these hormones get secreted into the portal venous bloodstream, which takes them to the liver. Here, these hormones are metabolized into inactive compounds, so they don't cause hormone-related effects. However, keep in mind that carcinoid tumors can metastasize to the liver. In this case, the metastatic tumor secretes the hormones directly into the hepatic veins, bypassing liver metabolism. This allows hormones to remain active and travel to different parts of the body, ultimately causing hormone-related effects. Okay, now one of the main effects caused by histamine and bradykinin is skin vasodilation, or dilation of skin blood vessels. On the other hand, serotonin can trigger bronchoconstriction, where airways become narrower, along with gastrointestinal fluid secretion and peristalsis, or contraction of the intestinal wall that moves food forward. Serotonin can also cause fibrosis or thickening of the heart valves, most often affecting the right side of the heart. This can result in tricuspid valve regurgitation, where the tricuspid valve doesn't close properly, so blood can escape from the right ventricle to the right atrium during systole, as well as pulmonary valve stenosis, where the pulmonary valve doesn't open properly to allow blood flow from the right atrium to the right ventricle during diastole, so it builds up. In contrast, remember that the left heart typically is not affected. That's because serotonin is inactivated in the lung vessels before reaching the left heart. Now, fibrosis can also affect the abdominal mesenteries and the retroperitoneal area, where it may cause ureteral obstruction and impair kidney function. Another high-yield fact for your tests is that serotonin is made from the amino acid tryptophan. This means that the increased synthesis of serotonin by carcinoid tumors might reduce the amount of tryptophan available to make niacin or vitamin B3. Now, all of these hormone-related effects can cause symptoms that are collectively called carcinoid syndrome. So carcinoid syndrome most commonly manifests with episodes of flushing, which involve a sudden reddening and warmth over the skin of the face, neck, and upper chest that's often accompanied by itching. These episodes are typically triggered by alcohol or emotional stress, and that's a high-yield fact. Other key symptoms of carcinoid syndrome include dyspnea, or shortness of breath, and wheezing, which is a whistling sound in the chest, as well as watery diarrhea and abdominal pain. In addition, fibrosis of the right heart valves can manifest as symptoms of right-sided heart failure, such as peripheral or lower leg edema and ascites, which is when fluid builds up in the peritoneal cavity. Finally, niacin deficiency can lead to pellagra. This manifests with a classic triad of the 3 Ds, so diarrhea, dementia, and dermatitis. Keep in mind that this dermatitis presents with rough, scaly, and sometimes hyperpigmented skin lesions. Diagnosis of carcinoid syndrome relies on blood tests, which can show high levels of serotonin and histamine. For your exams, it's important to remember that the metabolism of serotonin in the liver yields a byproduct called 5-hydroxyindolacetic acid, or 5-HIAA, which can be detected in the blood or urine. Another high-yield finding are prominent rosettes on biopsy, which are characteristic for carcinoid tumors. Treatment of carcinoid tumors involves surgical resection of the primary carcinoid tumor in the intestines and of the metastatic tumors in the liver. To keep symptoms of carcinoid syndrome under control, individuals may take somatostatin analogs, such as octreotide, which inhibit hormone release from neuroendocrine cells. If somatostatin analogs fail, they can be combined with tryptophan hydroxylase inhibitors, such as telotristat, which inhibit the synthesis of serotonin from tryptophan. All right, let's switch gears to pancreatic islet cell tumors. The pancreas contains small clusters of neuroendocrine cells called islets of Langerhans, which mainly consist of beta cells that secrete insulin, alpha cells that secrete glucagon, and delta cells that secrete somatostatin. In addition, there are a few rare cell types that are scattered in the islets of Langerhans, such as D1 cells that secrete vasoactive intestinal peptide, or VIP, and G cells that secrete gastrin. Pancreatic islet cell tumors often occur in the context of multiple endocrine neoplasia, or MEN type 1, which is a genetic condition that typically arises from a mutation in the MEN1 gene, which is a tumor suppressor gene. For your exams, remember that MEN1 is characterized by the development of benign or malignant tumors of the pituitary gland, parathyroid gland, and pancreas. Now, depending on the cell of origin, the most common pancreatic islet cell tumors include insulinomas, glucagonomas, somatostatinomas, VIPomas, and gastrinomas. All right, let's start with insulinomas, which arise from beta cells. Normally, beta cells produce insulin by cleaving a precursor molecule called proinsulin into insulin and C-peptide. Insulin then lowers our blood glucose by increasing its uptake by tissues, especially skeletal muscles and adipose or fat tissue. So with insulinoma, abnormally high levels of insulin lead to hypoglycemia or low blood glucose. This results in a variety of symptoms, including loss of consciousness, sweating, and tremor. Now for your tests, you should definitely know the 3 criteria suggesting that hypoglycemia is due to an insulinoma, collectively called Whipple triad. So, first, symptoms of hypoglycemia occur in episodes, especially during periods of fasting or after heavy exercise. Second, low blood glucose is measured at the time of the symptoms. And third, symptoms resolve as soon as glucose levels go back to normal. Now, for the diagnosis of insulinoma, it's important to measure blood levels of insulin and C-peptide. This allows us to distinguish between hypoglycemia caused by an insulinoma and hypoglycemia due to an injected exogenous insulin. High insulin and high C-peptide levels point to an insulinoma. On the other hand, high insulin levels but low C-peptide means the hypoglycemia is caused by exogenous insulin. That's because exogenous insulin suppresses the production of endogenous insulin along with C-peptide. The ultimate treatment of insulinoma is surgical removal of the tumor. If surgery cannot be performed, medications like diazoxide or somatostatin analogs like octreotide can be given to inhibit insulin release from beta cells. Next is glucagonoma, which arises from alpha cells that secrete the hormone glucagon. Normally, glucagon leads to the breakdown of proteins into amino acids, which will then be used in the liver to make glucose through a process called gluconeogenesis. With glucagonoma, there's overproduction of glucagon, which ultimately leads to hyperglycemia or high blood glucose. Symptoms of glucagonoma can be remembered as the 6 Ds. The first D stands for diabetes mellitus, which is characterized by hyperglycemia. The second D is for declining weight, caused by the excess breakdown of protein from tissues. Additional high-yield effects of glucagon are diarrhea, as well as dermatitis. This typically presents with necrolytic migratory erythema, which is a red, blistering rash that mostly affects the face, perineum, and limbs. It's called migratory because it resolves in one area of the body to migrate or appear in another. And this is a high-yield fact. Glucagonoma can also increase the risk of deep vein thrombosis, where clots block blood flow in veins, especially those in the lower extremities. Finally, individuals may experience psychiatric manifestations like depression. The diagnosis of glucagonoma is based on blood tests which show high glucagon levels along with high blood glucose. Treatment of glucagonoma relies on somatostatin analogs such as octreotide, which inhibits the release of glucagon from alpha cells. Ultimately, surgical resection should be done to remove the tumor. Moving on to somatostatinoma, which arises from delta cells that secrete somatostatin. And for your exams, keep in mind that somatostatinomas may also arise from delta cells in the intestinal mucosa. Normally, somatostatin inhibits the secretion of other gastrointestinal hormones and the most high-yield ones include secretin, cholecystokinin, gastrin, and insulin. Secretin stimulates the liver to increase bile production, which is stored in the gallbladder. On the other hand, cholecystokinin stimulates the gallbladder to contract to release the stored bile into the intestine to help with fat digestion and absorption. Gastrin stimulates hydrochloric acid secretion in the stomach, and remember that this is the main component of gastric acid. Finally, insulin lowers our blood glucose by increasing its uptake by tissue cells. In somatostatinomas, excess somatostatin inhibits the release of these hormones. So with low levels of secretin and cholecystokinin, the secretion of bile will be impaired. As a result, fat in the consumed food can't be properly digested and absorbed, so it gets excreted in the stools. At the same time, the decreased bile flow will promote gallstones formation. This can result in obstructive jaundice, where gallstones lodge in the biliary tree, causing the bilirubin to seep out into the blood. On the other hand, low gastrin will lead to achlorhydria, or the absence of hydrochloric acid in the stomach. Finally, inadequate insulin can result in hyperglycemia, leading to the development of glucose intolerance or diabetes mellitus. Symptoms of somatostatinoma include steatorrhea, meaning greasy, floating, voluminous, and terribly foul-smelling stools, which contain a high amount of undigested fat. This might be accompanied by abdominal pain, as well as jaundice or yellowish discoloration of the skin. For diagnosis of somatostatinoma, blood tests would show high somatostatin levels, in addition to hyperglycemia. The main treatment of somatostatinoma is surgical resection of the tumor. In addition, to help relieve the symptoms, somatostatin analogs like octreotide can be used to inhibit the release of gastrin. The next pancreatic neuroendocrine tumor is vipioma, which arises from D cells that secrete vasoactive intestinal peptide, or VIP. Normally, VIP stimulates the intestinal secretion of water and electrolytes like potassium and inhibits gastric acid secretion. So vipioma results in WDHA syndrome, which stands for its main symptoms. The first one's watery diarrhea, which leads to dehydration and electrolyte abnormalities. The main electrolyte that's affected is potassium, resulting in hypokalemia or low potassium in the blood. Last but not least, vipiomas lead to achlorhydria. Diagnosis of vipiomas relies on measuring VIP levels in the blood. Treatment of vipiomas starts by correcting the dehydration and electrolyte abnormalities, followed by surgical removal of the tumor. All right, the last neuroendocrine pancreatic tumor is gastrinoma, which arises from the G cells in the pancreas or the duodenum. Now, gastrinomas secrete large amounts of gastrin, which goes to the stomach and stimulates oversecretion of hydrochloric acid. Ultimately, this results in Zollinger-Ellison syndrome, where excess hydrochloric acid erodes the mucosa, giving rise to peptic ulcers. What's unique about Zollinger-Ellison syndrome is that the peptic ulcers are typically multiple and occur not only in the stomach and duodenum, but also in more distant locations of the small intestine like the jejunum. And this is an extremely high-yield fact. Now, the excess hydrochloric acid can also inactivate the digestive enzymes in the intestinal lumen. As a result, food, and especially fat, is forced to pass right through the intestines undigested and gets excreted in the stools. Now, symptoms of Zollinger-Ellison syndrome include abdominal pain and heartburn, as well as hematemesis or bloody vomiting if there's a bleeding ulcer. These symptoms are often accompanied by steatorrhea and weight loss. Diagnosis of gastrinoma and Zollinger-Ellison syndrome requires upper gastrointestinal endoscopy to visualize the ulcers. Thick gastric folds might also be seen due to the excess stimulation of the stomach by gastrin. Additionally, blood tests are performed to look for a high serum gastrin level, typically greater than 1,000 picogram per milliliter. Now, a very high-yield test is secretin stimulation test, in which secretin is administered to see how the body responds. Normally, secretin inhibits gastrin secretion by the G cells. However, gastrinoma cells are resistant to the inhibitory action of secretin, so the level of gastrin remains high even after secretin administration. The main treatment of gastrinoma is surgical resection. Treatment of Zollinger-Ellison syndrome includes the use of proton pump inhibitors or PPIs for short, which decrease gastric acid secretion. In addition, somatostatin analogs, like octreotide, can be given to inhibit the release of gastrin and help relieve symptoms. All right, as a quick recap, neuroendocrine tumors arise from neuroendocrine cells, which are most commonly found in the gastrointestinal organs. Now, carcinoid tumors secrete a variety of hormones like serotonin, histamine, and bradykinin, which can lead to carcinoid syndrome. Symptoms of carcinoid syndrome include flushing, abdominal pain, diarrhea, right-sided heart failure, and pellagra, which manifests with a triad of diarrhea, dementia, and dermatitis. Moving on to pancreatic islet cell tumors, insulinoma arises from beta cells and causes excessive insulin secretion. The clinical features of insulinoma are known as the Whipple triad, which consists of episodes of hypoglycemia during fasting or after exercise, characterized by symptoms like loss of consciousness, sweating, and tremor, as well as low blood glucose measured during the episodes, and resolution of symptoms when glucose goes back to normal. Glucagonoma arises from alpha cells that secrete excessive amounts of glucagon, leading to hyperglycemia. Symptoms of glucagonoma include diabetes mellitus, declining weight, diarrhea, dermatitis, deep vein thrombosis, and depression. Somatostatinoma arises from delta cells that secrete somatostatin, which inhibits the secretion of secretin and cholecystokinin, leading to steatorrhea and gallstones. Somatostatin also inhibits gastrin, which results in achlorhydria, as well as insulin, which causes hyperglycemia, leading to glucose intolerance or diabetes mellitus. Next is VIPoma, which arises from D cells that secrete large amounts of vasoactive intestinal peptide, or VIP, leading to WDHA syndrome, which is characterized by watery diarrhea, hypokalemia, and achlorhydria. Finally, gastrinoma arises from G cells in the duodenum or pancreas and causes excessive gastrin secretion. This increases gastric acid production, leading to Zollinger-Ellison syndrome, which is characterized by peptic ulcers in the stomach, duodenum, and in distant locations like the jejunum. Symptoms of Zollinger-Ellison syndrome include heartburn, abdominal pain, steatorrhea, and weight loss. And now back to our cases. Clara is a 27-year-old female with abdominal pain and watery diarrhea, as well as episodes of flushing that are triggered by alcohol and emotional stress. On clinical examination, you found peripheral edema, which points to right-sided heart failure. These findings combined to make you think of carcinoid syndrome. A key clue is the urine test, revealing an elevated level of 5-HIAA, which is a byproduct of serotonin breakdown. The diagnosis is confirmed via CT scan, which reveals a mass in the appendix, as well as several metastatic masses involving the liver, which is typical of carcinoid tumors. On the other hand, William is a 65-year-old male who presents with persistent heartburn and abdominal pain. This, combined with the fact that he has been experiencing steatorrhea and significant weight loss, suggests Zollinger-Ellison syndrome. This is confirmed with an upper gastrointestinal endoscopy, which reveals multiple ulcers. The final clue is a sky-high gastrin level of 1,400 picograms per milliliter, which makes this a pretty straightforward case of gastrinoma.
On the endocrinology ward, 2 individuals came in. The first person is 47-year-old Melania, whom recently went through a surgical procedure called thyroidectomy due to thyroid cancer. Melania came in with tetany, and on the clinical examination, there was a positive Vostek sign. The other person is 55-year-old Emma, who came in with constipation, muscle weakness, and bone pain. She has a history of kidney stones, specifically calcium stones, and she also said that she's been feeling down lately. Calcium, phosphate, and PTH levels were taken in both individuals. Melania had low levels of calcium, high levels of phosphate, and low levels of PTH, whereas Emma had high levels of calcium, low levels of phosphate, and high levels of PTH. Both individuals seemed to have a problem in their parathyroids. First, A bit of physiology. The 4 parathyroid glands are on the posterior of the thyroid gland, and their main job is to keep blood calcium levels stable. Changes in the body's levels of extracellular calcium and phosphate levels are detected by the surface receptor in the parathyroid's chief cells. Both decreased calcium levels and increased phosphate levels can signal the chief cells to release more parathyroid hormone, or PTH. PTH affects many organs. In the bones, it binds to osteoblasts, the bone-building cells, and causes them to release rank ligands, or rank L, along with monocyte colony stimulating factor, or MCSF. These will cause osteoclast precursors to mature into osteoclasts, which break down bones and release calcium and phosphate into the blood. PTH also gets the kidneys to reabsorb more calcium and excrete more phosphate. It also activates calcitriol, also known as 1,25-dihydroxycholecalciferol, or active vitamin D. Active vitamin D then goes on to cause the gastrointestinal tract to increase calcium absorption. Altogether, these effects help to increase extracellular levels of calcium when they're low. Now, let's talk about hypoparathyroidism, where there's an abnormality with the parathyroid glands, so PTH levels are low. The most common cause is removal of the parathyroid glands during thyroid or parathyroid surgeries. Another cause is an autoimmune condition that destroys parathyroid glands. There are also genetic causes like DiGeorge syndrome, which causes a variety of immune and birth defects. With DiGeorge syndrome, the 3rd and 4th pharyngeal pouches don't develop, so the parathyroid glands and thymus that originate here will be missing in the infant. Then, there's pseudo-hypoparathyroidism, where PTH levels are normal or high, but the kidneys and bones don't respond to PTH, which is called PTH resistance. An example is pseudo-hypoparathyroidism, type 1A, or Albright hereditary osteodystrophy, which is an autosomal dominant condition. The cause is a mutation in the GS protein alpha subunit, and this mutation is inherited from the mother. GS proteins function as cellular signaling proteins, and where there's a defect in the alpha subunit, in this case, the PTH receptor in the bones and kidney won't be able to activate, and so PTH cannot exert its effects. With Albright osteodystrophy, classical symptoms include shortened 4th and 5th digits, short stature, obesity, and developmental delay. Now, there's also pseudo-hypoparathyroidism, which is a subtype of Albright's hereditary osteodystrophy, and it also includes symptoms like brachydactyl, developmental delays, and short stature. However, the gene is passed on by the father instead of the mother, and there's no PTH resistance. So there's normal PTH and calcium levels. Now let's look at the symptoms caused by low levels of parathyroid hormone or the lack of response to them. Both will lead to hypocalcemia and hyperphosphatemia, which results in more excitable neurons. This can lead to tetany, or the involuntary contraction of muscles. The spontaneous firing of neurons leads to Voss-Teck sign, which is when facial muscles twitch after the facial nerve is lightly tapped, usually 1 centimeter below the zygomatic process. It can cause Trousseau's sign, which is where a blood pressure cuff applies pressure on the brachial nerve, which is enough to make it fire, resulting in a muscle spasm that makes the wrist and metacarpophalangeal joints flex. If the hypocalcemia and hyperphosphatemia are severe, this can lead to life-threatening complications like severe seizures and cardiac arrhythmias. Let's move on and talk about hyperparathyroidism. There are 3 types of hyperparathyroidism: primary, secondary, and tertiary. In primary hyperparathyroidism, the parathyroid gland is responsible for the protein because it makes parathyroid hormone independently of the calcium level. Most often, primary hyperparathyroidism is caused by a parathyroid adenoma, a benign tumor. Rarely, primary hyperparathyroidism is caused by hyperplasia, where parathyroid cells divide excessively, causing growth of the glands, and in very rare cases, there can be a carcinoma of the parathyroid glands. The symptoms of primary hyperparathyroidism can be remembered, especially for exams, as stones, thrones, bones, groans, and psychiatric overtones. Now, hyperparathyroidism causes hypercalciuria, which can lead to dehydration and can stimulate the formation of calcium-based kidney stones and gallstones. Thrones refers to the toilet to remind you of the polyuria or frequent urination that results from impaired sodium and water reabsorption. Bones is for bone pain that results after chronic hormone-driven demineralization in order to release calcium. Groans is for constipation and muscle weakness, both of which are partly due to decreased muscle contractions. The excess calcium makes neurons less excitable, which leads to slower muscle contractions and diminishes neuron firing in the central nervous system. As a result, there are psychiatric overtones, which refers to symptoms like depression and confusion. In addition, excess PTH will cause osteoclasts to break down bone and makes the kidneys hold on to calcium and get rid of phosphate, resulting in hypercalcemia and hypophosphatemia. Eventually, bone resorption by osteoclasts can lead to a condition called osteitis fibrosa cystica, where there are cystic bone spaces that are filled with osteoclasts and hemosiderin, and they're called brown tumors. Classic signs include subperiosteal erosions that affects the phalanges in the fingers, and salt and pepper sign in the skull, which refers to the numerous small lesions caused by bone resorption. Osteitis fibrosa cystica is classically associated with primary hyperparathyroidism, but can be seen sometimes with secondary hyperparathyroidism too. With primary hyperparathyroidism, labs show hypercalcemia, hypophosphatemia, high levels of PTH, high alkaline phosphatase, or ALP, due to increased bone resorption, and high levels of cAMP in the urine due to hypercalcemia. In secondary hyperparathyroidism, the parathyroid gland is normal, but it makes excess parathyroid hormone in response to chronic hypocalcemia due to another cause. Most often, the problem is chronic kidney disease, where the kidneys cannot excrete phosphate properly or make enough calcitriol. The hyperphosphatemia reduces the amount of free calcium ions in the blood by binding with them, and the lack of calcitriol means less calcium is absorbed by the intestine. Secondary hyperparathyroidism can present with symptoms of chronic kidney disease, as that is often the underlying cause. Other secondary hyperparathyroidism symptoms include bone resorption, called renal osteodystrophy, and calcification in blood vessels and soft tissues, because the high levels of phosphate stick to any available calcium, forms bone-like crystals that deposit in different tissues. Labs show hypocalcemia, hyperphosphatemia, low levels of vitamin D, as well as high PTH levels, usually above 50 picograms per milliliter, and high ALP levels. Tertiary hyperparathyroidism is basically a situation where individuals who have had secondary hyperparathyroidism for many years develop primary hyperparathyroidism. Specifically, parts of the parathyroid gland start making parathyroid hormone independently of blood calcium levels, resulting in hypercalcemia. Labs show really high levels of PTH and hypercalcemia. Another condition is familial hypocalciuric hypercalcemia, or FHH. This is a genetic disorder caused by defective calcium sensing receptor in the parathyroids and the kidney. These receptors are less sensitive to calcium levels in the blood, so the parathyroids might overproduce PTH. When the kidneys cannot sense calcium levels, they will increase calcium reabsorption, leading to hypocalciuria and hypercalcemia. The elevated PTH and hypercalcemia might make you think of primary hyperparathyroidism, but the key difference that FHH causes hypocalciuria, while primary hyperparathyroidism can have normal or hypercalciuria. FHH is typically benign, and the person will be asymptomatic. All right, as a quick recap, problems with the parathyroid gland can cause hypo or hyperparathyroidism, which leads to calcium imbalance. The most common cause of hypoparathyroidism is removal of the parathyroid glands during thyroid or parathyroid surgeries. Other causes include autoimmune and DiGeorge syndrome. All of these lead to decreased PTH levels and hypocalcemia. Next, there's pseudohypoparathyroidism type 1A, or Albright hereditary osteodystrophy, and this is caused by PTH resistance in the bones and kidneys. This also causes hypocalcemia, but PTH levels are increased. Finally, we have pseudo-hypoparathyroidism, where there's the same bone deformities and developmental problems as Albright hereditary osteodystrophy, but the PTH and calcium levels are normal. Symptoms and signs of hypocalcemia include tetany, positive Vostek and Trousseau signs. Moving on to hyperparathyroidism. Primary hyperparathyroidism is most often caused by a single parathyroid adenoma, but can also be caused by hyperplasia and carcinoma of the parathyroids, all of which increases PTH release. The symptoms of primary hyperparathyroidism can be remembered as stones, thrones, bones, groans, and psychiatric overtones. Over time, osteitis fibrosa cystica can develop. Labs will show increased PTH, hypercalcemia, and hypophosphatemia. Familial hypocalciuric hypercalcemia will also have hypercalcemia and sometimes moderately elevated PTH, but there will be hypocalciuria. In secondary hyperparathyroidism, the parathyroid gland makes excess parathyroid hormone in response to chronic hypocalcemia, like in chronic kidney disease. Labs show hypocalcemia, hyperphosphatemia, low levels of vitamin D, as well as high PTH levels. Tertiary hyperparathyroidism is basically a situation where individuals who have had secondary hyperparathyroidism for many years develop primary hyperparathyroidism. Labs show really high levels of PTH and hypercalcemia. Back to our cases. Melania came in with tetany and positive Vostek sign, both suggesting hypocalcemia. Labs showed hypocalcemia, hyperphosphatemia, and low PTH. Based on history, symptoms, and signs, and labs, Melania is suffering from hypoparathyroidism, probably caused by the recent removal of her thyroid, which also removed the parathyroid glands. Emma came in with constipation and muscle weakness, as well as bone pain. She also has a history of kidney stones, and lately she has been feeling low, suggesting she might be depressed. All of these signs, stones, bones, groans, and psychiatric overtones, suggest primary hyperparathyroidism, which is then confirmed by the labs: hypercalcemia, hypophosphatemia, and high levels of PTH. Imaging studies of the parathyroids were done, and a PTH-secreting adenoma was found.
While doing your rounds, you see a 6-year-old named Alex who presents with severe headaches and vision impairment, which began 6 months ago. More specifically, he has some difficulty seeing things on the periphery, what he describes as tunnel vision. Examination reveals bitemporal hemianopia and a much taller stature than expected for his age, with disproportionately long arms and legs. Soon after, you see Maria, who says she has been unsuccessfully trying to have a baby for the last 2 years. She also mentions that she hasn't had her menstruation in 3 months, but had milky nipple discharge. Hormone serum measurements were performed in both, showing an increase in insulin-like growth factor 1 levels in Alex and an increase in prolactin levels in Maria. Now both seem to have a disease affecting the pituitary. But first, a bit of physiology. The pituitary is a small gland situated in a tiny bony space called a sella turcica. It is linked to the hypothalamus by the pituitary stalk, and it is divided into the anterior pituitary and the posterior pituitary. The posterior pituitary is not glandular. Thus, it doesn't make its own hormones. Instead, it stores and secretes oxytocin and antidiuretic hormone, which are produced in the hypothalamus. By contrast, the anterior pituitary has 5 types of hormone-producing cells. First, lactotrophs secrete prolactin, which stimulates breast milk production and inhibits ovulation and spermatogenesis. Second, somatotrophs secrete growth hormone, or GH. GH acts directly on target tissues to stimulate growth and development. Then, corticotrophs secrete adrenocorticotropic hormone, or ACTH for short. ACTH makes the adrenal glands secrete cortisol. Cortisol is in charge of the stress response and keeping blood pressure and blood sugar in the normal range. Fourth, thyrotrophs secrete thyroid-stimulating hormone, or TSH. TSH makes the thyroid gland release thyroid hormones T3 and T4. Thyroid hormones speed up the basal metabolic rate in all cells, so it keeps cellular processes going at an optimal rate. And finally, gonadotroph cells secrete luteinizing hormone, or LH, and follicle-stimulating hormone, or FSH, that stimulate ovarian or testicular production of sex cells and sex hormones. Now, most pituitary tumors are adenomas, which are benign tumors. These tumors could arise spontaneously, but may also be associated with certain disorders, like multiple endocrine neoplasia type 1, or MEN1, where tumors also develop in the parathyroid glands and the pancreas. Okay, so when a pituitary adenoma is under 1 centimeter across, it is called a microadenoma. Because these tumors are small, they rarely cause any symptoms and are usually incidental findings on brain imaging. If the tumor is larger than 1 centimeter across, it's called a macroadenoma. As they grow, macroadenomas can press on the normal parts of the pituitary and cause severe headaches and hypopituitarism, which is when one or all of the anterior pituitary hormones are decreased. If the tumor grows superiorly, it can compress the nearby optic chiasm, which is where the optic nerves partially cross. This leads to visual abnormalities, like bitemporal hemianopia, or narrowing of the vision field, a very high-yield fact to remember. If it extends laterally, it can invade the cavernous sinus, a structure made of venous channels located on both sides of the sella turcica, and press on the nerves that pass through it. This causes cavernous sinus syndrome. The syndrome consists of ophthalmoplegia, which is weakness or paralysis of the muscles involved in eye movement due to compression of cranial nerves 3, 4, and 6, decreased corneal and maxillary sensations due to compression of cranial nerve 5, and Horner syndrome due to compression of the sympathetic plexus within the sinus. Remember that Horner syndrome is a combination of miosis, decreased pupil size, ptosis, a drooping eyelid, and anhidrosis, or decreased sweating. Both micro and macroadenomas can be non-functional or functional. Now, most non-functional adenomas grow for a really long time without causing any trouble, until reaching the size of a macroadenoma. Macroadenomas present with compression symptoms, especially headache, bitemporal hemianopia, and double vision. Sometimes, hypopituitarism features, like impaired growth, sexual dysfunction, and intolerance to cold, might also develop. Another possible consequence is pituitary apoplexy, occurring when the blood vessels of the adenoma rupture and cause a hemorrhage that compresses the blood vessels of the pituitary itself. Symptoms are similar to those caused by compression, like bitemporal hemianopia and severe headaches, but meningeal signs like neck stiffness can also be present. Because blood supply to the pituitary is obstructed, this leads to pituitary ischemia, necrosis, and loss of pituitary function. Non-functional adenomas are usually diagnosed by brain MRI, while pituitary hormone screening might also show a decrease in hormone levels in those with hypopituitarism. Treatment of symptomatic individuals consists of transsphenoidal surgery. Asymptomatic adenomas smaller than 2 centimeters, however, can be monitored with an MRI, visual field testing, and screening for hormone hypo or hyper secretion. Functional adenomas, on the other hand, often lead to an excess of hormones. First, lactotroph adenomas, or prolactinomas, are the most common type. Now, what you need to know is that normally, prolactin secretion is controlled by the hypothalamus, which inhibits its production by releasing dopamine via the tuberoinfundibular pathway and stimulates its production via thyrotropin-releasing hormone, or TRH. Prolactin also causes negative feedback by inhibiting its own secretion since it causes dopamine release from the hypothalamus. However, when there's too much prolactin, dopamine inhibition is lost, and the hypothalamus can't regulate prolactin production anymore. Now, a macroadenoma can also obstruct the flow of dopamine from the hypothalamus, but compared to prolactinomas, the elevation in prolactin is usually mild and under 100 nanograms per milliliter. In premenopausal females, the main symptom of hyperprolactinemia is galactorrhea, or a milky nipple discharge outside of breastfeeding or pregnancy. Now, another high-yield consequence is that excess prolactin suppresses hypothalamic production of gonadotropin-releasing hormone, or GnRH, which leads to the pituitary secreting less LH and FSH. And without gonadotropin stimulation, gonads can't secrete sex hormones like estrogen and progesterone, causing hypogonadism. Hypogonadism symptoms can include infertility, amenorrhea, which is absent menstruation, and vaginal dryness. Osteoporosis is another consequence that's frequently tested, which can occur due to loss of bone density secondary to decreased estrogen levels. And as a result, these female individuals tend to suffer fragility fractures. Males typically develop decreased libido, impotence, infertility, gynecomastia, and rarely galactorrhea. Most individuals can also present with compression symptoms like bitemporal hemianopia and headaches as well. A brain MRI scan showing the tumor's size and extent, and a blood test showing high serum prolactin levels confirm the diagnosis. Treatment relies on dopamine agonists like cabergoline or bromocriptine that inhibit prolactin secretion just like dopamine would. If the tumor is large, transsphenoidal resection could be attempted. Somatotroph adenomas make growth hormone and are the second most common type of pituitary adenoma. Excess growth hormone causes different symptoms in children versus adults. In children, it causes gigantism, which is an increase in body size and height with disproportionately long arms and legs. Something to remember is that these kids can get really tall, because unlike other causes of gigantism, GH doesn't accelerate epiphyseal closure of the bone, which is responsible for linear growth. In adults, it causes acromegaly, where there is enlargement of the bones of the skull, hands, and feet. Other possible features of acromegaly include a large tongue with deep furrows, deep voice, diaphoresis, which is excessive sweating, impaired glucose tolerance, and increased risk of colorectal polyps and cancer. In both gigantism and acromegaly, there can also be enlargement of visceral organs, like the heart. Screening for a somatotroph adenoma is actually a high-yield topic. It's done by measuring insulin-like growth factor 1, or IGF-1 levels, which is a liver-produced hormone through which GH stimulates long bone growth. This is because daily GH secretion is pulsatile, but it stimulates the liver to release a constant amount of IGF-1 throughout the day. If high levels are detected, an oral glucose tolerance test is performed, where serum GH is measured before and after glucose administration. This is because in healthy people, a higher blood glucose level usually causes the body to stop producing GH. If GH levels stay the same, growth hormone hypersecretion can be diagnosed. Brain MRI might also be required to assess the location and size of the tumor. Treatment consists of transsphenoidal resection. If surgery is unsuccessful, medical therapy is done with dopamine agonists like cabergoline or a GH receptor antagonist like pegvisomant. Some cases might also require radiotherapy. Corticotroph adenomas secrete excess ACTH, causing Cushing disease. Cushing disease is different from Cushing syndrome. Cushing syndrome refers to all the symptoms caused by high cortisol levels, which can be caused not only by Cushing disease, but many other conditions, including ACTH-secreting ectopic tumors or adrenal tumors. Okay, so possible symptoms include a change in fat distribution causing moon facies, a round, full moon-shaped face, buffalo hump, which is a fatty deposit on the upper back, and truncal obesity, where fat accumulates around the abdomen and trunk rather than in the limbs. Cushing disease can also result in skin hyperpigmentation. This is due to increased levels of melanocyte-stimulating hormone, or MSH, which signals melanocytes to produce a lot of melanin, turning the skin darker than normal. This occurs because ACTH shares a common precursor with MSH called pro-opiomelanocortin. So when ACTH production increases, more MSH is also produced. Okay, so diagnosis is based on elevated serum ACTH and elevated 24-hour urinary cortisol levels. However, keep in mind that a high-dose dexamethasone suppression test is also needed to distinguish between a pituitary or an ectopic secretion of ACTH. Dexamethasone is a synthetic corticosteroid that provides negative feedback to the pituitary gland, resulting in suppression of ACTH production. So, if after the test, ACTH and cortisol levels drop, it means the elevation was caused by a pituitary tumor. If the levels stay the same, it means there's an ectopic source of ACTH. Treatment is also transsphenoidal resection, but if the entire tumor can't be removed, then radiation therapy can be used. Therapy with drugs that block the adrenal synthesis of cortisol, like metirapone, can also be initiated to control the symptoms. If medications aren't sufficient to block the cortisol effects, a last resort is to surgically remove both adrenal glands. Gonadotropin and thyrotropin secreting pituitary tumors are extremely rare and usually cause compression symptoms. Gonadotropin releasing tumors cause excess FSH and LH, leading to gonadal hyperstimulation and consequently to high levels of sex hormones. Thyrotropin secreting tumors cause excess TSH, which leads to hyperthyroidism and as a result, excess T3 and T4. Diagnosis is based on elevated serum levels of FSH, LH, and sex hormones for gonadotropin-secreting tumors, and of TSH and T4 in thyrotropin-secreting tumors. First-line treatment consists of transsphenoidal resection, followed by radiotherapy in the case of surgical failure. Another benign tumor of the pituitary that you might come across is craniopharyngioma. It is the most common childhood supratentorial tumor, which is an area located above the tentorium cerebelli. The tumor originates from the residual anterior pituitary embryonic tissue called Rathke's pouch. Symptoms depend on the tumor's location. If it involves the area of the pituitary gland itself, the tumor can cause partial or complete pituitary hormone deficiency, leading to hypopituitarism. If it compresses the pituitary stalk, a high-yield fact is that it can decrease the secretion of antidiuretic hormone from the posterior pituitary, leading to diabetes insipidus, and symptoms like extreme thirst and increased urinary output and frequency. A large craniopharyngioma can increase prolactin levels by interfering with hypothalamic dopamine release, causing galactorrhea, and also causing compression symptoms like headaches and bitemporal hemianopia. Diagnosis is based on a contrast brain MRI, which can show calcified cysts with cholesterol crystals. Screening for pituitary hormone deficiencies should also be done, since it can be associated with cortisol deficiency. And if that is the case, treatment with hydrocortisone should be initiated before the tumor is removed surgically. Radiotherapy can be used when surgery is unsuccessful. There's also Nelson syndrome, which is characterized by abnormal hormone secretion, enlargement of the pituitary gland, and the development of large and invasive adenomas. It typically occurs after a few years in around 1/4 of those who undergo surgical removal of the adrenal glands for Cushing disease. Because the adrenal glands are removed, it leads to cortisol deficiency, and this increases corticotropin-releasing hormone, or CRH production, within the hypothalamus. As a result, the ACTH-secreting pituitary adenoma that caused Cushing disease in the first place gets even bigger. Symptoms associated with Nelson syndrome include abnormal skin hyperpigmentation, headaches, bitemporal hemianopia, and amenorrhea. Diagnosis is based on history, brain MRI, and increased ACTH serum levels. Treatment consists mostly of transsphenoidal resection and radiotherapy. And finally, malignant tumors like pituitary carcinomas are super rare. Actually, pituitary carcinomas look like adenomas under a microscope and can lead to the same symptoms. The only way to tell them apart is when the tumor spreads to another part of the body. Most often, pituitary carcinoma spreads to the brain, spinal cord, meninges or the covering of the brain and spinal cord, or bone around the pituitary. Treatment is also similar to adenomas. Alright, as a quick recap, non-functional adenomas present with compression symptoms like headaches and visual impairment, hypopituitarism, and can cause pituitary apoplexy. Functional pituitary adenomas can cause similar symptoms, but also overproduce pituitary hormones. The most common type is prolactinomas. In premenopausal females, symptoms consist of galactorrhea, amenorrhea, infertility, and osteoporosis. Males usually develop a decreased libido, impotence, infertility, and gynecomastia. Next up is growth hormone secreting pituitary adenomas, which cause gigantism in children and acromegaly in adults. ACTH secreting pituitary adenomas cause Cushing disease and symptoms like a full moon facies, buffalo hump, and truncal obesity. For non-adenoma tumors, we have craniopharyngioma, which is the most common childhood supratentorial tumor, and symptoms are caused by mass effect. Nelson syndrome is characterized by abnormal hormone secretion, pituitary enlargement, and large and invasive adenomas following surgical removal of the adrenal glands for Cushing disease. Symptoms associated with Nelson syndrome include abnormal skin hyperpigmentation, headaches, bitemporal hemianopia, and amenorrhea. Finally, pituitary carcinomas are rare and cause the same mass effects as the other pituitary tumors. However, they can metastasize to other parts of the brain, spinal cord, and bones. Now back to our cases. Alex presents with a history of severe headaches and bitemporal hemianopia. Examination reveals taller stature than expected for his age, with disproportionately long arms and legs. His clinical picture is highly suggestive of gigantism secondary to a growth hormone secreting tumor. Another clue was the increase in IGF-1 levels. Further testing should include a GH level after an oral glucose tolerance test and brain MRI to confirm the diagnosis. Maria presents with a history of infertility and amenorrhea, and examination revealed galactorrhea. The presence of galactorrhea suggests hyperprolactinemia, which was actually confirmed by hormone serum measurements. The next step would be brain imaging to confirm the presence of a pituitary tumor.
Thyroid nodules are lumps on the thyroid gland that are different from normal thyroid tissue. They're actually fairly common, and they're often felt on palpation, or they're discovered incidentally, like during a CT scan of the head and neck. There may be a single nodule or multiple nodules, and sometimes they form on a pre-existing goiter, which is when the thyroid is enlarged. This can happen because of an autoimmune attack on the thyroid gland, like with Hashimoto's thyroiditis or Graves' disease. The key thing to identify is whether or not the nodule is benign or is a thyroid cancer. The thyroid is sensitive to radiation, so an important risk factors for thyroid cancer is prior radiation to the head or neck region, which might have been given for another malignancy in the area like lymphoma. Other risk factors for thyroid cancer include a family history of thyroid cancer or being over age 65, since nodules are more likely to be malignant in older individuals. Because thyroid nodules are fairly uncommon in young individuals, if they appear in a person below 20 years of age, they're more likely cancerous. Finally, having symptoms related to the nodule like voice changes or a hoarse voice, or difficulty breathing or swallowing, suggests that the nodule is invading adjacent tissues and structures, a sign of thyroid cancer. On a physical examination, a nodule is more likely to be thyroid cancer if it's firm and hard on palpation, or if it's fixed, meaning it doesn't move when the individual swallows. However, it's worth mentioning that physical exam findings are unreliable in the presence of goiter. Another warning sign is the presence of a swollen lymph node in the neck region, especially when the lymph node doesn't hurt on palpation and is only on one side. The next step in evaluating the risk that a thyroid nodule is cancerous is getting a TSH level and a thyroid ultrasound. Depending on the results of these tests, a fine needle aspiration may or may not be needed. Now, TSH is normally secreted by the pituitary gland, which responds to negative feedback from thyroid hormones. So high levels of thyroid hormones normally means a low TSH. In a functional nodule, there's a low TSH and high thyroid hormone level, and that's good news, because there's a low risk for functional nodules to be malignant. If TSH is low, a radioactive iodine uptake scan, or RAIU for short, is done to confirm that the nodule is functional. In an RAIU scan, the person is given either a capsule or a liquid that contains the radioactive isotope of iodine, typically iodine 123. Functional thyroid tissue loves iodine and gobbles it up to make thyroid hormones. So to see how much thyroid tissue is actively making hormones, we perform a scintigraphic scan. The principle is simple. The more active the thyroid is, the more iodine it takes in, and as a result, the more radiation it emits. Then, a gamma camera is used to pick up the emitted radioactive signal, and a computer translates this into pictures with a white background, where the dark areas represent radiation emitted by the functional thyroid tissue. A set of these scans is obtained 4 to 6 hours later, and then another set is obtained 24 hours later. A normal thyroid gland looks like 2 gray wings on an RAIU scan, and if functional nodules are present, they appear darker than the rest of the thyroid. If only one nodule is present, the diagnosis is toxic adenoma, and if there's more than one nodule, we call that toxic multinodular goiter, because many nodules typically form on a pre-existing goiter. These two conditions are usually treated with radioiodine therapy. The way it works is a person swallows a capsule containing a small dose of iodine 131, which emits radiation, which is different from the iodine 123 that's used in the RAIU scan. Functional thyroid tissue takes in this iodine just the same though, and the iodine destroys it with radiation, like a Trojan horse. The person may go home after swallowing the capsule, but shouldn't have prolonged close contact with pregnant women and young children for 3 days, and should drink plenty of fluids so that the iodine is rapidly flushed out of their system. Now let's switch gears and look at non-functional nodules, which are associated with a normal or high TSH and a normal thyroid hormone level. These nodules are more likely to represent thyroid cancer, so here's where ultrasonography comes in handy. On an ultrasound, The normal thyroid gland is medium in terms of echogenicity, so it looks like a light gray butterfly with its wings on either side of the trachea. Normally, the thyroid gland is homogeneous, but nodules are like glitches in that neat homogeneous medium. Ultrasound can also pick up deep nodules that can't be felt on palpation and give a sense for their size, shape, margins, composition, which can be solid, cystic, or mixed, and echogenicity, meaning that if they're hypoechoic or hyperechoic. Ultrasonography can also see if there are calcifications inside the nodules. Taking all of this into consideration, ultrasonography can classify nodules as high, intermediate, low, and very low risk. High-risk nodules are solid and hypoechoic, meaning they're darker than the thyroid gland and have worrying features like irregular margins, microcalcifications, which appear as white spots, or extension beyond the thyroid. Intermediate risk nodules are solid and hypoechoic, but don't have the additional worry features. A fine needle aspiration is indicated in high and intermediate risk nodules greater than 1 centimeter in diameter. Low-risk nodules are solid or partially cystic, isoechoic or hyperechoic, meaning they have the same shade as the thyroid gland, or they're whiter, and they also don't have any of the worrying features. In this case, a fine needle aspiration is only recommended if the nodules are greater than 1.5 centimeters in diameter. Finally, very low-risk nodules are spongy or partially cystic and have no worrying features. For these, a fine needle aspiration is only recommended if they're greater than 2 centimeters in diameter. A bonus category is a purely cystic nodule, which is almost always benign, so a fine needle aspiration is not recommended for these at all. If a fine needle aspiration isn't indicated, then the individual should get another ultrasound in 6 to 12 months. If a fine needle aspiration is indicated, then the good news is that it's a quick and safe procedure. A very fine hollow needle is put into each thyroid nodule using ultrasound guidance, and 2 to 4 aspirations are taken from each one. The samples are stained and examined under a microscope. If the cells look like regular thyroid cells, then the nodule is benign, and follow-up depends on ultrasound findings. Benign nodules that are high risk based on ultrasound findings should be followed up with an ultrasound and a fine needle aspiration within 12 months. Benign nodules that are low to intermediate risk based on ultrasound can be followed up with an ultrasound in 12 to 24 months. Finally, if a fine needle aspiration was performed for a very low-risk nodule and the biopsy results are benign, a repeat ultrasound can be done after 24 months. If the cells look abnormal, then the nodule is considered malignant, and, depending on the cells it originates from, the four most common types are papillary, follicular, medullary, and anaplastic. Papillary and follicular derive from follicular thyroid cells, and they're considered differentiated thyroid carcinomas. Medullary thyroid cancer originates from calcitonin-producing C cells, but it's not considered a differentiated type of thyroid cancer because C cells have a different embryological origin than thyroid follicular cells. Finally, anaplastic cancer is considered undifferentiated. Papillary thyroid carcinoma accounts for over 85% of thyroid cancer cases, and on microscopy, the nuclei have characteristic clefts, grooves, and holes, so they look clear and empty, and they're classically described as orphan Annie eyes. Follicular thyroid carcinoma, on the other hand, is very hard to differentiate from a follicular adenoma, its benign counterpart. So if the fine needle aspiration shows follicular lesions of undetermined significance, or FLUS, then molecular testing of fine needle aspirates or a diagnostic lobectomy may need to be done. In a diagnostic lobectomy, the entire lobe of the thyroid which contains the nodule is removed and examined in order to confirm the diagnosis. Next, there's medullary thyroid carcinoma, which is derived from thyroid C cells. Those are the cells scattered between the thyroid follicles that secrete calcitonin. That's why calcitonin levels are usually elevated in medullary thyroid carcinoma. Sometimes medullary thyroid carcinoma may be present in the context of multiple endocrine neoplasia, or MEN syndromes, types 2A and 2B. Both MEN 2A and 2B present with medullary thyroid cancer and pheochromocytoma, but MEN 2A has extra tumors on the parathyroid glands, whereas MEN 2B is associated with multiple neuromas, which are tumors that come from nerve tissue in the skin, gastrointestinal tract, and mouth. Because of the associated tumors, individuals may present with additional symptoms, like diarrhea and flushing. Treatment of thyroid cancer is primarily surgical. For follicular and papillary thyroid cancer, either the entire thyroid or part of it is removed, and the extent of removal depends on the size and location of the tumor, as well as the presence of lymph node or distant metastases. However, these procedures come with a risk of complications, like seromas, which is when a pocket of serous fluid accumulates at the site of surgery, or hematomas, which is when blood builds up. Hoarseness and dysphagia are also common complications immediately following surgery, but they usually resolve on their own. If the thoracic duct is damaged, child fistulas may also develop, and in this case, there may be a milky discharge or a bulging supraclavicular fossa. If the recurrent laryngeal nerve is accidentally damaged during surgery, that may cause vocal cord paresis or paralysis, as well as voice changes. Finally, surgery may cause esophageal or tracheal injuries. Okay, now after a total thyroidectomy, high-risk individuals will need to also undergo radioiodine therapy to ensure that all tumor cells, as well as normal thyroid cells, are removed. Then, lifelong therapy with T4 is given to replace normal thyroid hormone production and to suppress TSH secretion in order to prevent tumor regrowth. While on T4 therapy, serum thyroglobulin levels are measured every 3 to 6 months to check for persistent or recurrent disease, and individuals are followed with an ultrasound every 6 to 12 months. Medullary thyroid cancer is always treated with a total thyroidectomy. 2 to 3 months later, serum calcitonin and carcinoembryonic antigen, or CEA, are measured to check for residual disease. Finally, there's the undifferentiated anaplastic variety of thyroid cancer. This is rare and very aggressive. By the time of diagnosis, it has usually invaded surrounding tissues like the trachea and the larynx, and sometimes even metastasized to other sites like the lungs. On microscopy, there's extensive necrosis, and there can be different cell types, like spindle cells, giant cells, or squamoid cells. If there's no metastases, then treatment is a complete thyroidectomy, as well as chemotherapy and radiotherapy. If there are metastases and surgery is not an option, then palliative care is usually recommended, and participation in a clinical trial should be considered. Alright, as a quick recap. Thyroid nodules can be functional or non-functional. Low serum TSH indicates functional nodules, which are confirmed by an RAIU scan and treated by radioiodine therapy. Normal or high serum TSH indicates non-functional nodules, which can be either benign or malignant. On ultrasonography, the most suggestive findings for a malignant nodule are irregular margins, microcalcifications, and extrathyroidal extension. On ultrasonography, high and intermediate risk nodules greater than 1 cm, low risk nodules greater than 1.5 centimeters, and very low risk nodules greater than 2 centimeters need a follow-up fine needle aspiration. If the fine needle aspiration reveals a thyroid cancer, then differentiated thyroid cancers like papillary or follicular thyroid carcinoma are treated with partial or total thyroidectomy. After a total thyroidectomy, postoperative radioiodine therapy and lifelong therapy with T4 are needed. A total thyroidectomy, followed by lifelong T4 substitution, is also done for medullary thyroid carcinoma. Undifferentiated thyroid carcinoma is treated with total thyroidectomy, as well as chemo and radiotherapy when it doesn't present with metastases. If metastases are present, palliative care is recommended.
On the endocrinology ward, 2 individuals came in. Both individuals complained about feeling a lump on their necks, but reported no other symptoms. The first one is 49-year-old Dasha, who, as a child, lived close to Chernobyl. The other one is 27-year-old Mike, whose family history involves multiple endocrine neoplasia type 2A. On exam, they each had a painless mass on their thyroids. Both people had normal T3, T4, and TSH levels. They underwent thyroid echography, which showed cold nodules. Afterwards, fine needle biopsies were done. Both individuals had tumors on their thyroids. First, let's refresh some info on the thyroid. The thyroid gland is an endocrine gland located in the neck. The thyroid gland is made up of thousands of follicles, which are small spheres lined with follicular cells. Follicular cells convert thyroglobulin, a protein found in follicles, into 2 iodine-containing hormones, triiodothyronine, or T3, and thyroxine, or T4. Once released from the thyroid gland, these hormones enter the blood and bind to circulating plasma proteins. Once inside the cell, T4 is mostly converted into T3, at which point it can exert its effect. T3, among other effects, speeds up the basal metabolic rate, increases cardiac output, stimulates bone resorption, and activates the sympathetic nervous system. The thyroid is also made up of parafollicular or C cells, which are near the follicles. These cells produce calcitonin, a hormone that lowers blood calcium levels by inhibiting osteoclasts. Calcitonin also inhibits renal tubular cell reabsorption of calcium, allowing the calcium to be excreted into the urine. Now, DNA mutations can cause thyroid cells to become cancerous. For example, a mutation might change a proto-oncogenes like RET and BRAF, which are genes that code for proteins that promote cell growth and proliferation, into oncogenes. That would mean that the proteins force the cell to be stuck in the on position, always dividing, and that causes the thyroid cell to turn into a tumor. There are other genes, called tumor suppressors, like TP53, that normally slow down cell division or make cells die if they divide uncontrollably. DNA mutations might also turn off tumor suppressor genes, which allows thyroid cells that try to divide uncontrollably to go unchecked. Let's start by talking about thyroid adenomas, which are benign and solitary growths of the thyroid. A high-yield fact is that typically, these nodules are non-functional, so they don't produce thyroid hormones, and these are called cold nodules. In rare cases, the nodules can produce hormones regardless of TSH secretion, in which case they're called hot or toxic nodules and they can lead to hyperthyroidism. On histology, thyroid adenomas are follicular, and there's no capsular or vascular invasion. Moving on to thyroid carcinomas, of which there are 3 types: differentiated, medullary, and anaplastic. Let's start talking about differentiated thyroid cancer. The cancer arises from follicular cells, and it's known as differentiated because the cancer cells look like a normal thyroid cell. Within the differentiated thyroid cancers, there are 2 types of cancer that you'll have to know for your exams: papillary carcinoma and follicular carcinoma. Now, papillary carcinomas are the most common form of thyroid cancer, and this is high yield. Thankfully, they have an excellent prognosis. They're associated with RET, PTC rearrangements, and BRAF gene mutations, as well as exposure to ionizing radiation during childhood. The name papillary refers to the fact that these tumors have finger-like prolongations of follicle cells, known as papillae, that tend to grow slowly towards nearby lymphatic vessels and invade nearby lymph nodes in the neck. Under the microscope, the nuclei of papillary carcinoma cells contain very few proteins and a small amount of DNA. and that gives the appearance of an empty nucleus, sometimes called an orphan Annie eye nucleus based on an old famous cartoon character. Another feature are psammoma bodies, which are calcium deposits within the papillae, and you'll absolutely have to remember this for your exams. The second type, follicular carcinomas, represent the second most common form of thyroid cancer, and they have a good prognosis. This type of thyroid cancer is associated with the activation of RAS oncogene and PAX8 PPAR gamma translocations, which promotes proliferation. In follicular carcinomas, the tumor develops from the follicular cells and grows until it breaks through the fibrous capsule. Unlike papillary thyroid carcinomas, from there, follicular carcinomas can invade into nearby blood vessels and spread to other parts of the body. So, moving beyond the differentiated thyroid cancers, there are medullary thyroid carcinomas, which arise from C cells. Most of the time, it forms because of a spontaneous mutation in the RET oncogene, and it's usually a single carcinoma in one lobe of the thyroid. Another high-yield fact is that it's associated with a hereditary condition called multiple endocrine neoplasia, or MEN, types 2A and 2B. In these conditions, one or more of the endocrine glands like the thyroid gland, parathyroid gland, and adrenal gland develop tumors. Under the microscope, medullary thyroid carcinoma is made up of spindle-shaped cells, which are called that because they're long and skinny, like a spindle that's used to spin fibers into thread. C cells in the tumor make excessive amounts of calcitonin, which deposits between the C cells. As the calcitonin deposits, the resulting clumps of protein stick together and form fibrous deposits called amyloid around the C cells, which can be seen with Congo red stain. Finally, there are the anaplastic thyroid carcinomas, which are associated with mutations in the TP53 tumor suppressor gene. Anaplastic thyroid carcinomas are a rare form of thyroid cancer that usually appears in older individuals and has a poor prognosis. The altered cells don't look anything like normal thyroid cells. It may be that these tumors derive from an existing papillary or follicular cancer, where the cells mutate even more and become unrecognizable. They often grow beyond the fibrous capsule of the thyroid gland and invade nearby structures. Most often, the first sign of thyroid cancer is a solitary, painless nodule in the thyroid gland. Typically, hard and immovable nodules are more likely to be tumors. If the tumor gets too big or invades the larynx or esophagus, it can cause hoarseness and trouble swallowing. Albeit thyroid adenomas can sometimes cause hyperthyroidism, thyroid cancers are non-functional, so they usually don't present with signs of hyper or hypothyroidism. The diagnosis of thyroid cancer often begins with imaging studies, like a thyroid ultrasound, which can help identify a thyroid nodule. Calcitonin levels are usually elevated in medullary thyroid carcinomas. A radioiodine scan can also be useful. That's where radioactive iodine is ingested and taken up by cells that make thyroid hormone. Usually, thyroid tumors don't make thyroid hormone, so they appear as cold nodules. The diagnosis of thyroid cancer is usually confirmed by doing a fine needle aspiration, where a thin needle is used to take small tissue samples from the thyroid nodule. Treatment often involves partial thyroidectomy, after which complications can appear. First, there can be hypothyroidism if a large portion of the organ is removed. Hoarseness can occur due to damage to the right recurrent laryngeal nerve, which innervates most of the muscles in the larynx. There could also be damage to the external branch of the superior laryngeal nerve that innervates the cricothyroid, which can prevent the person from raising the pitch of their voice. Hypocalcemia can also occur due to the removal of the parathyroid glands. All right, as a quick recap, thyroid adenomas are benign and solitary growths on the thyroid. Most often, they are non-functional, but in rare cases can cause hyperthyroidism. Next, there are three main types of thyroid cancer: differentiated, medullary, and anaplastic. Differentiated thyroid carcinomas arise from follicular cells. The most common are papillary carcinomas, and they're associated with RET, PTC rearrangements, and BRAF gene mutations, as well as exposure to ionizing radiation during childhood. On histology, there are orphan Annie eye nucleus and psammoma bodies. The second is follicular carcinomas, which are associated with the activation of RAS oncogene and PAX8 PPAR gamma translocations. Moving beyond the differentiated thyroid cancers, we have medullary thyroid carcinomas, which arise from C cells and are often associated with RET mutations and MEN types 2A and 2B. Finally, there are the anaplastic thyroid carcinomas. These are a rare form of thyroid cancer that usually appears in older individuals and are associated with TP53 mutations. The diagnosis of thyroid cancer is done with fine needle aspiration, and treatment often involves thyroidectomy. Back to our cases. Dasha came in with a lump in her neck, and echography confirmed that it was a cold thyroid nodule. After doing a fine needle aspiration, histology showed empty appearing nuclei with central clearing, the so-called orphan Annie eyes, and Samoma bodies. Her history of living close to Chernobyl, by that we mean that she may have been irradiated, plus histology suggests that she has papillary carcinoma. Mike also came in with a cold thyroid nodule, but in this case, histology showed spindle-shaped cells and amyloid around C cells. His family history of MEN type 2A and histology suggests medullary carcinoma. If genetic testing were to be done, it would probably show RET gene mutations.